अरे देखिए
सर शुरू कर सकते हैं अभी.
Okay. So good morning to all from FOGSI ICOG. This program we are having every second Sunday of the month at 11:30 a.m. and this is FOGSI ICOG tutorial, and we are very thankful to Dr. Rishikesh Pai sir, President FOGSI, whose initiative we have started this as a PG tutorial, and Dr. Lakshmi Srikhande is our chairman ICOG, and under whose guidance or whose motivation we are able to do this program. Along with me is Dr. Hafizur Rahman and Dr. Ashish Mukhopadhyay. We all three are coordinating this program on FOGSI ICOG platform, and this is the initiative we have started to have at least PG teaching, so that we are doing case discussions and we can have uniform pattern all across the country. And the important message which is we want to give it for this tutorial is that we are having students from different part of the country. We have teachers across the country from different medical colleges and different part of the institutes, so that we have all the inputs and for a case, and we will able to have a wide discussion, and we will able to know the various practices involved in various corner of the country, so that we will be having a wider knowledge and updates about these topics. We every month we take a topic of importance, so that students are prepared for their exam, and it is a mock exercise which we are doing, so that students can have a good discussion in their exam with their examiners, and if they have any confusion, anything, they can also discuss it here. We have recording of all our previous discussion on our website, which is ICOG website, and you can get access to that by logging in. There is no password. You can have recording. You can see the discussion there, whatever cases we have taken. And in this year also, we are planning to have a calendar of the cases, and then we will be following that, and we will discuss all the important cases. And every month we are doing 2 cases, and we have again the faculty from different parts of the country. And today we are having faculty from Patiala, Dr. Manjeet Mohi, Dr. Archana Kumari from Ranchi, Dr. Gauri Dorai Rajan from Puducherry, Dr. Sarita Bhalera from Mumbai, and Dr. Rajesh Rade from Latur. And we have students from Shri Krishna Medical College, Muzaffarpur, Bihar, and All India Institute of Medical Sciences, Raipur. So we hope we will have a very good discussion. I just want to inform you that our president, Dr. Rishikesh Pai, and Chairman Dr. Lakshmi Srikhande is not able to join today. Let's see if they have time, they will join in between. Otherwise, we will continue and we will have their message and blessing in the next program. And next, this is also to inform you that next program will not be on the second Sunday of the month, because we have All India Congress of Obstetrics and Gynecology at Kolkata, AICOG. So we will be having our program on following Sunday. That means after that, 15th of January. So we will be sending you all the messages for that. At the moment, I now invite Dr. Hafizur Rahman to proceed with the program. Thank you very much.
Thank you, sir. Good morning. Good morning, everyone. As Ashok sir said, that is, we are thankful to our FOGSI president, Dr. Rishikesh Pai, the ICOG chairperson, Dr. Lakshmi Srikhande madam. Those are always supporting, along with the Dr. Ashok Kumar, secretary ICOG. So we did the program last year entirely, almost every second Sunday of the month. So this is the program Newly, we are having in the tenure of Dr. Lakshmi Srikanta Madam, along with the support of all of our ICOG members and participation of all students. So as we have already said, that is, we have previously recording of all the programs, and we have faculties from all over India as well as students every time from all over India is there. So for this month, that is the students are from the SKMCH, that is Muzaffarpur, Bihar, where they are guided very nicely by Dr. Avarani Sinha Madam. And the students are Dr. Kumari Bandana and Dr. Preeti, who will present a case on intra-uterine and growth retardation. I hope it will be very much helpful. And we have faculties in none other than our very Dr. Ashok Kumar sir. He is a professor and head Department of Obstetrics and Gynecology at RML and Atal Bihari Vajpayee Institute of Medical Science at Delhi. Then we have Dr. Manjeet Mohi. So Madam is currently professor and head in Gynecology and Obstetrics Department. There is Gyan Sagar Medical College and Hospital that is in Patiala, and she was formerly head of the department at GMC Patiala. Then we have Dr. Archana Kumari. Madam is at Ranchi, that is Ranchi Institute of Medical Sciences. She had more than 15 years of experience, both undergraduate as well as postgraduate students. Then following that, that is, we'll have the students from AIMS Raipur. They are guided by Dr. Sarita Agarwal, and they will be presenting a case of recurrent pregnancy loss and how to go about it. I hope it will be very helpful to the students. That is, they are Dr. Farhad Jahan Khan and Dr. Akriti Singh. So the faculties are Dr. Gauri Dorai Rajan. Madam is HOD at head of the department at Jipmar Puducherry, and she has lots of experience and teaching as well as guiding the postgraduate student, and many awards Madam is having. Then we have Dr. Sarita Bhalirao. Madam will join a little while later. That is, she's our ICOG Governing Council member as well as a very renowned gynecologist as well as teaching in the DNB student, that is at Bridge Candy Hospital and Bhatia Wadia Maternity Hospital at Mumbai. Then we have Dr. Rajesh Daradev. So sir is again, he's been very much associated in the teaching the students. He was formerly associate professor at Gop Medical College at Latur and presently in Vaishnavi Hospital and Endoscopy Center, which is again a postgraduate institution for teaching. So we don't want to waste much time. So for the first case, I would like to request that the students of SKMCH, that is Sri Krishna Medical College Muzaffarpur, and to share their screen, that is Dr. Kumari Bandana and Dr. Preeti. And I would like to request the faculties to take over place in taking their case as well as have some insightful discussions. So Bandana and Preeti, please share your screen and start presenting.
Let me in between thanks all our faculty who have joined, who has spared their valuable time for this PG discussion. And I request all faculty to participate in each case. There is no such boundary that you are in the first case or the second case. We request you to be there throughout the session, and you can give your input so that students are benefited for both the cases.
Yes.
Thank you very much.
Yes, Bandana and Preeti, please introduce yourself and start.
Good morning to all our respected teachers and seniors. I am Dr. Kumari Vandana from Sri Krishna Medical College.
I am Dr. Preeti from Sri Krishna Medical College, and we are going to present case on fetal growth restriction. My patient, Mrs. Gunja Kumari, third gravida, para 2, abortion 0, living 2, 29 years old, resident of Aurai, Muzaffarpur. She is housewife by occupation and educated up to 10th standard. Her husband is Mr. Keshav, 38-year-old farmer, educated up to 10th standard. Her socioeconomic, she belongs to low socioeconomic status according to modified Kupuswamy scale. Date of admission was 19th of November 2022, and I examined her on 21st November 2022. Her first day of last menstrual period was 12th March 2022 and EDD is 19th December 2022. Chief complaints. Patient presented with amenorrhea of 36 weeks with reduced fetal movement since last 24 hours in our ANC OPD at SKMCH. Now coming to the history of presenting illness. Patient was perceiving fetal movements well previously. Then she presented with reduced fetal movements. She was perceiving only 5 to 7 fetal movements since last 24 hours. There was no history of leaking per vaginum, bleeding per vaginum, pain abdomen, headache or swelling of the feet. Coming to the history of present pregnancy. First trimester history. Patient conceived spontaneously. Pregnancy was confirmed after 1.5 months of missed period by UPT at PHC. Folic acid tablets were taken. USG was done at 2.5 months. She told that it was told by her doctor that it was normal. She was also taking aspirin. She had complaint of nausea in her first trimester. There was no excessive vomiting, fever with rashes, spotting or bleeding per vaginum, pain abdomen, or increased frequency of micturition. There was no history of exposure to radiation and any other drug intake. Now coming to the second trimester history, quickening was felt at 5 months of gestation. USG was done at 4.5 months and was told there were no anomalies in fetus. Iron and calcium tablets were taken, injection TT taken, no history of any other drug intake or radiation exposure, no history of bleeding per vaginum, no history of swelling of feet or headache. Coming to the third trimester history, she continued taking iron and calcium tablets. USG was repeated at 8 months and patient was told that fetus was growing well. Fetus was not growing well. She was advised for follow-up every 15 days, and she was advised to keep a watch on fetal movement daily. She presented at 8.5 months with less fetal movement since 24 hours. There was no history of high blood pressure or swelling of feet, no abdominal pain, or no history of bleeding per vaginum or leaking per vaginum. Past obstetric history. Her first pregnancy was in the year 2013. She had no antenatal complications. She had taken iron folic acid tablets and immunized against TT. The labor was spontaneous spontaneous onset, and there was meconium staining of liquor and fetal distress, for which LSCS was done. Her postpartum period was uneventful. She delivered a live male, cried after resuscitation, admitted to NICU for 2 days. Baby weight was 2.8 kg, breastfed for 2 years and immunized. Her second pregnancy was in the year 2015. She had 3 antenatal visits and taken iron calcium tablets and injection TT booster dose. There was reduced fetal growth in third trimester. Labor event was uneventful and mode of delivery was LSCS. She delivered a live female child, cried immediately after birth, breastfed for 2 years, and the baby weight was 2.2 kgs. Coming to the past history, there was no history of diabetes mellitus, hypertension, asthma, TB, or cardiac disease. There was no history of previous surgery other than LSCS. There was no drug allergy, no previous history of blood transfusion. Coming to the menstrual history, she attained her menarche at the age of 14 years. Past cycles are regular. 28 days cycle, duration was 3 to 4 days, flow was average 2 to 3 pads per day. There was no history of dysmenorrhea, passage of clots. Her first day of last menstrual period was 12th of March 2022 and EDD is 19th December 2022. Coming to her family history, there was no history of diabetes, hypertension, and other chronic diseases in the family. No history of growth restricted baby in family. There was no history of children with any chromosomal anomaly or birth defect. Coming to the personal history, she took mixed diet. Appetite was normal. Sleep was undisturbed. Bowel and bladder habits are normal and regular. There is no history of any addiction or drug abuse. Dietary history, she is vegetarian. She is vegetarian, and total calorie intake was 960 kilocalorie as per 24-hour recall, and for protein intake was 44 grams per day. Now I hand over to Dr. Vandana for examination part.
Now I'm going to present the examination part. Coming to general.
Hello. Excuse me.
Yes,
Can we
yes.
discuss on history a bit?
Okay, ma'am.
In the history, you have just told first thing. I'll just like to tell that just once you have said that she is third gravida, P2, A0, and L2. So I think once you have already written third gravida with 2 living issues, there is no need to write A0. Number 1. Number 2, you must follow the Williams obstetrical formula, which is in the 4 digits. I think this method of writing is not the proper for postgraduates. So you must write as gravida P1 0 plus 0 plus 0. So that is the proper way to write down. First is for the term pregnancies, then for preterm, then for abortion, and then for the number of living issues. So that explains itself everything. Then in your writing, you have said that you have examined your patient. Your patient was admitted on 19th of November. And you examined her on 21st of November. Okay.
Yes,
This is what you have written.
Yes,
And
ma'am.
what I have gone through your slides, that the patient was operated upon as soon as she was admitted, because she was showing end diastolic flow as the slides which have been sent to us. So I do not know what was done when you examined the patient. When your patient was delivered, on which date? She delivered on which date? Do you remember it? Because you have already, the slides are with us anyway. Okay, no problem. And then there is a one thing that I think as far as postgraduates are concerned, they're not supposed to give the history in trimester wise. Trimester wise history, we always say, should be given by the undergraduates. Since you have to just tell the story completely in a package form. So first trimester, second trimester story, not, I think, as far as postgraduates are concerned, not properly acceptable. And then you said that your patient was taking tablet aspirin. Who advised her to take aspirin? You have not mentioned. Where she was, it means that whosoever has advised her to take the tablet aspirin must have evaluated her properly and must have told her that in this pregnancy she may be having some complications.
So she was coming for regular follow-ups in the first trimester because she had previous history of one fetal growth restricted baby. So she was advised by the doctors. By
your hospital?
No, ma'am. Some other doctor.
Some other hospital. Okay.
Yes.
Okay. But then you must tell which hospital, because I thought she may be with you people. Okay. Then in the she has only 2 ultrasounds, one in the 4.5 months and one in the 8th month.
Yes,
Am I right?
2.5 months.
In first trimester at 2.5 months, then at 4.5 months, and last one at 8.5 months.
2.5 months, 4.5 months, and then is at the 8th month.
Yes.
So she has reported to you only once in the last 8th month when she was admitted to you. Prior to that, she has never come to you?
She came in third trimester at 8th month. Then we advised her to follow up, to come for regular follow-up after 15 days for monitoring in view of her previous history.
At 8th month means that at about 35 weeks, isn't it?
Yes, ma'am.
Do you remember the date when she came to you? Because if she has come already at 35 weeks to you, then ultrasound might have shown some changes. Because at 36 plus 6 weeks, she is showing absent end-diastolic flow, which is not possible to occur within about 6 or 7 days or 10 days. It takes long time. It means that the ultrasound done at
Maybe.
35 weeks might have missed something, or the interpretation was not done properly. I just want an explanation for this. Can you give me explanation? Do you have the report of ultrasound on the 8th month, which was done in your hospital or wherever it was done?
She didn't show. She just verbally told that she underwent ultrasonography at 8 months. Report was not with her.
Patient
No,
is
you.
not compliant. She didn't visit regularly to our NCOPD.
No. But she was taking aspirin. She has got basic ultrasound at 2.5 months, 4.5 months, and at 8 months at your
Normal.
hospital. So you cannot say blame the patient.
Yes, sir.
Okay. So I'll just want to know that what was the report of ultrasound of 8th month? Because if she has reported to you at 8th month, and at 36 weeks she is having absent and diastolic flow, so where the things went wrong? Once she was at 8 months or 35 weeks with you, then why we were not able to catch at that particular time? Because she reported to you in the emergency with the absent or the decreased fetal movements.
In that
Isn't it?
yes, ma'am.
So these are my few queries which I would like to, if you can answer me, otherwise we can continue in the future. And there is one thing more, is the kicking of the baby. You said that the baby was initially she was having 15 to 20 movements per day.
Yes, ma'am.
But now only for one day, she felt only 5 to 6 movements in the one day prior to that, to the admission.
Yes, ma'am.
Okay, this is what you told.
Yes, ma'am.
So absent movement or the decreased fetal movement for one day, and that too was recorded by a patient who is, you say, is not compliant, is how reliable? Okay, so this is again puts me, because if a patient is absolutely feeling normal fetal movements a few days back and only one day history is there of decreased fetal movements, it's very difficult to believe me that I should admit the patient otherwise until unless I have got some other parameters with me. Okay.
Okay, so I just add here that Dr. Mohi, madam, has rightly said, and we have also emphasized this many times, that we should use the formula of GP1, A1P and preterm labor, 4-digit formula, because it has come in the books now, in your textbook. So we insist now with all the students that they should be presenting in that manner. Earlier we were not very insistent on that because it was not there in the books, but now it is in the William. So postgraduate should follow that, number one. Number two, as madam has also told, we agree that there is a lacuna in the history. We wanted to clarify so many things in the history, but we could not get any answer. Now, can I ask you, in other words, students, tell me, how will you look for the fetal movement? Just we will spend 2-3 minutes here, and then we'll go into the examination.
First of all,
yeah.
First of all, we will ask the patient about her previous fetal movement and when she came to our ANC with reduced fetal movements. As she was telling that previously she was receiving regular fetal movements, approximately.
No, I am only interested. How will you ask the patient to record fetal movement?
Yes, ma'am. We will tell her to either we will tell her to start counting from any day of the any time of a day, and as soon as she completes her approx 12 counts, approx 10 counts in 12 hours, then we will ask her to stop that. It means that it is adequate. In 12 hours, if she is receiving 12 counts per day, per 12 hours, then it is adequate.
Okay,
or we
this
can,
is the one method. Yeah.
One method, yes, sir. Or we can tell her to take recordings after morning meal, after lunch for 1 hour, then for evening for 1 hour. If it is then we will multiply the countings, fetal counts into by 4, and it will give the
no. See, we ask the patient to lie in left lateral position after meal for 1 hour, and we ask her to concentrate on her fetal movement, and even we sometimes ask the patient to put her hand over both the hands over the abdomen so that she can feel also, perceive also the movement. And we ask the patient to lie down in the left lateral position, and she has to do this for 3 times in a day, after breakfast, after lunch, after dinner. And if in each hour her movements are more than 3 to 4 in 1 hour, then we say it is adequate. So whenever patient comes to us with decreased fetal movement, we ask her, at least we cannot do 12-hour fetal this cardiac count to 12 to 10, then we ask the patient only for 1 hour movement, and we see in 1 hour if she is not feeling movement, then we go for all the tests, because as madam has also told you that the history and the patient compliance sometimes creates a doubt in our mind. So once we have to objectively assess whether the fetal movements are less or not, right? So these things are important in the history, and you should have taken into consideration and told us all these points in the history. Okay, so we move out in the examination.
Now coming to examination part. First is general physical examination. My patient is moderately built and average nourished, says conscious, cooperative and well oriented to time, place and person. Her pre-pregnancy weight is 50 kgs. Her height is 150 centimeter and the BMI comes to 22.22 kilogram per square meter, which was pre-pregnancy BMI. Her tongue, teeth and gums were normal. There was mild pallor and there was no edema, icterus, clubbing, sinuses or lymphadenopathy. Her breast and thyroid were normal. So current weight was 59 kgs and weight gain during pregnancy was 9 kg. Vitals and systemic examination. Pulse rate was 88 beats per minute, regular in rhythm, normal in character, normal in volume. There was no radial or radiofemoral delay. Her blood pressure was 110 by 78 millimeter of mercury, which was taken in sitting position. Her respiratory rate was 14 per minute and temperature was 98.6 degree Fahrenheit. And in respiratory system examination, there was bilateral vesicular breathing sounds and no added sounds were present. In CVS examination, S1 and S2 was present and no murmur was present. On CNS examination, all reflexes were intact and no other abnormalities. In the skeletal system, no abnormality was seen. Coming to obstetric examination, on inspection, shape of the abdomen was longitudinally oval, distended, which appears full. Umbilicus was central and inverted. Linea nigra and stria gravidarum was present. Transverse Caesarean section scar was seen, and there were no prominent or dilated veins. Her hernial orifices were free on cuffing. On palpation, there was fundal height of 32 weeks. Abdominal girth was 31 inches. Infusio-fundal height was 32 centimeter, and Likert clinically appeared mildly reduced. On fundal rib, that is first Leopold, a soft, broad, and non-palatable mass was felt, which was suggestive of breach. In second Leopold, uniform curve resistance was felt on left side, and limbs were felt on right side. On third Leopold, hard, round, and palatable pole was felt, which was suggestive of cephalic presentation. In second Leopold, findings of third Leopold were confirmed. Fingers were converging, which was suggestive of non-engaged head, and head was 4/5 palpable. There was no scar tenderness. On auscultation, fetal heart sound was heard on left spino-umbilical line at the rate of 140 per minute, which was regular. So the summary is, this is a case of Mrs. Gunja Devi, 29 years old, resident of Arai, Muzaffarpur, belonging to low socioeconomic status, visited ANC in SKMCH on 98th November. She is married for 9 years, previous to LSCS, third gravida, para 2, live 2. Her last menstrual period was on 12th of March 2022, and the expected date of delivery was 19th December 2022. So presented to ANC OPD clinic with period gestation 36 weeks 1 day with complaints of less fetal movement since 24 hours, for which she was admitted. Tablet aspirin was started in first trimester, and she had previous history of growth restricted baby. Her obstetric history, her past obstetric history was first male child who is 9 years old, delivered by LSCS for fetal distress. Second was female child, 7 years old, delivered by LSCS. There was no significant family history of any children with birth defect or fetal growth restriction or chromosomal anomalies. Her past obstetric history had a history of IUGR baby. On general examination, her vitals were normal. There was mild pallor and no edema and other significant findings. On obstetric examination, a single live fetus with symphysiofundal height of 32 weeks of gestation was present. which was not corresponding to period of gestation of 36 weeks. Fetus was in cephalic presentation with non-engaged head. There was no scar tenderness and FHS was normal. So the provisional diagnosis is, this is a case of 29 years old third gravida, para 2, live 2, previous to LSCS with 36 weeks of gestation with single live fetus in longitudinal line, cephalic presentation, not in labor with reduced fetal movements. So it is probably a case of fetal growth restriction. Thank you, sir.
Okay. Now I invite my faculty to give comments about their summary and diagnosis. If there are
Yes,
no
sir.
issues with that, then we will proceed further.
No. As far as again in the history, I'm not very much satisfied. I just would like to ask them what was the indication for the cesarean for the second time. They have not told anything about that, because that makes a lot of problem for me.
Yes. Please answer, Dr. Vandana.
What was the indication for the cesarean section the second time? First time it was definitely because she was induced at 40 weeks and she had fetal distress and cesarean was done. Second time she must have been supervised somewhere. And was it elective cesarean section or was it emergency cesarean section, and what was the indication?
According to her ultrasonographic findings, and there was suspected there was
She was
fetal growth
told-
restriction, and as she was a case of previous cesarean section, so in view of this, emergency LSCS was done.
Do you want to say that which category of IUGR we will bring elective cesarean
It was
section?
in late onset fetal growth restriction.
So I think that was not the indication for doing the cesarean section, that particular in the second pregnancy.
So-
Cause maybe something else which is not elaborated properly. Anyway, your case you have written in a summary as a probably she is a case of fetal growth restriction. Why you have put this word probably? Tell me. Because your patient is almost 4 weeks lagging, and according to you, ultrasonography is showing absent diastolic flow.
Yes, because of absent diastolic flow. This is a case of fetal growth restriction, not probably.
So it was a rather clear-cut case of fetal
Clear
growth
cut case of
restriction.
fetal growth restriction. Yes.
Do not write it as probably. And you have written as in a summary, ultrasound showing single live intrauterine fetus with growth lag of 4 weeks with the reversal of diastolic flow with the non-reactive NST.
Yes, ma'am.
In the summary you have written with a non-reactive NST.
Yes, ma'am.
Okay, so we will be discussing in details about the NST in the details. So,
Madam, can I ask something?
no,
And
yes, ma'am. Please.
I fully agree with the madam. Why are you writing probable? Number one. So that means clinically, how do you diagnose growth restriction?
Clinically by
Yeah. What is the clinical indication to suspect growth restriction? What is the definition?
clinically if symphysiofundal height measurement is lagging by 3 centimeter corresponding to that period of gestation, we suspect IUGR.
Is that it?
And
Did you
and
mention
if
this
in
fundal
fundal,
height?
yes, ma'am.
32
And if
centimeters.
but symphysiofundal height measurement is more reliable than fundal height alone. If there is lag of 4 weeks to corresponding period of gestation, then we also suspect fetal growth restriction.
Correct. So do you think in your case there is a lag of 4 weeks or there
Yes,
is a lag
ma'am.
of 6 centimeters? Yes.
Ma'am, there was also a lag of 4 weeks. Our patient presented at 36 weeks, but
Correct,
the
correct.
fundal
So
height
why
was
this
30.
was probable? When you have everything
ma'am.
clinically telling you that there is growth restriction,
Yes.
you don't have to rely on scan. That scan shows AEDF. See, the argument you gave that there is growth restriction is that scan is showing AEDF. That means clinically our hands are not picking it up. That's not correct. You yourself said there is a 4 weeks lag and there is a 3 centimeter lag from the expected funnel height. So there is enough evidence clinically to say that there is growth restriction. Okay.
Yes, ma'am.
No, that is what I want to again emphasize, and I think my faculty will also agree that IUGR or FGR diagnosis, we have to first make clinically. If we suspect, then we go for the ultrasonography. But
Yes.
at the moment, it is being done in a reverse manner. So it is not the case. If we have to suspect on examination, which you have done because there is a lag in the fundal height and period of gestation. So we are suspecting, then only we will go for the ultrasound, and there we will find out the severity of the FGR by the Doppler parameter. This is what probably we all want to say.
Yes.
Any other comments from the faculty? Anyone? Dr. Archana, you want to add something here?
Yes, I would just like to emphasize that diagnosis has to be first made clinically, and then you have to do a vigilant antepartum surveillance methods to, decide the management part.
Yes, ma'am.
I have one more doubt. Maybe I didn't hear. There were some audio issues. I didn't hear you talk about the post-operative course during the cesarean section in either pregnancy. See, here the decision might be clear-cut that she is previous to LSCS. Your mode of delivery might be decided. But what if she was previous 1 LSCS? You did not bring out. You may get a case as a previous 1 LSCS. So you need to look at the TOLAC eligibility and all that. So you need to bring out the various post-operative aspects of cesarean. I don't think I heard that. So what are important issues that you will bring out?
Ma'am, because it was the case of previous one cesarean, and in this there was in second pregnancy there was confirmation of fetal growth restriction. So we didn't give a trial of TOLAC or VBAC.
No.
And we
You are not getting my point. In your first history of cesarean section,
Yes,
right?
ma'am.
In the cesarean section event that you were narrating obstetric reasons why cesarean was done, fetal distress. After that, you have not come out with certain important post-operative features as part of cesarean section post-operative period. I didn't hear you say that.
Ma'am, in that obstetric chart, we mentioned that there was post-perpural events were uneventful, or postpartum period was
No.
uneventful.
That is not enough. See, I should know what do you think is uneventful. You cannot wrap up by saying uneventful. You have to bring out what all have you actually looked into. So can you now tell me what do you understand or what are those important aspects that you will detail before you can call it as uneventful in a patient who's undergone a cesarean previous delivery?
Yes.
So tell me.
On from as per regular on the post of day 1, she told that flatus was as usual passed, and we allowed her for orally. On from the day we auscultated the bowel sound, and she started breastfeeding as soon as baby was delivered, and
No,
there
Vandana,
was
that
no
is not
complaint
your
of fever.
assessment.
There was no any postpartum hemorrhage or other any complaints from her side. Her stitches were also healthy at the time of examination, and we did the complete stitch removal and alternate stitch removal and complete stitch removal on day 5 and 6, and she was discharged uneventfully with.
A couple of things. In every puparium, especially in a previous cesarean section case, you said fever, but fever alone may not be representative of the infection we are worried about. What are the infection we are worried about? From the point of view of mode of delivery in the next pregnancy, what infection worries us? Fever can be because of UTI, breast abscess, mastitis, so many things. No. So what fever or what infection worries us from the point of view of planning the delivery in the next pregnancy? Tell me. When we look at eligibility criteria for TOLAC, no. So some infection worries us. We cannot try something when there is an infection. What infection? Infection where?
Beta, what? No,
So
where the
if
baby, beta, where the baby is going to lie in the uterus.
So infection where, ma?
Ah,
intrauterine infection.
Exactly. So how will
ah.
the patient have, what will she have in the post-operative period, which will alarm me that this patient had infection of the uterine wound?
Uh,
What is that history?
pains, civil complaint of pain, and
Anything else more than pain or even fever?
there will
That
be
negative
sub.
history. If the uterine wound gets infected, what would happen in the post-operative period? Hmm.
Uterine
Uterine infection. So that would cause foul-smelling lochia.
false smelling vaginal
This
discharge.
specific negative history has to come in every previous cesarean section. How long was the catheter kept? Was there any blood transfusion? And you have a case here which is growth restriction. Okay, we don't know what is the reason behind it. We all know that she is not hypertensive, correct? So, is there anything else that becomes important in the post-operative period to specify as a negative history?
Her post-op vitals were also
No,
stable.
no, 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 not vitals or something. I'll give you a clue. On the third day, the patient develops painful swellings in the leg.
If there is deep vein thrombosis.
Yes, that's important, no? Because there may be something underlying which has caused the growth restriction. On top of that, she's had a cesarean, she's immobilized. So these histories are important. You have to, it should be a leading question to specify, not say wrap up saying postpartum period was uneventful. Instead, say this particular history did not exist. No history of false smelling lochia, no history suggestive of deep vein thrombosis in the puberty period. Okay, go ahead.
The message from here is that when you are presenting history and examination, it is important that your history examination should complete everything, should not leave behind. Otherwise, you will be lost in the discussion with some points in the history as well as in the examination. And your viva will go somewhere else instead of FGR, which you have prepared yourself, right? So that you should remember for all everyone. And this is one exercise which clearly gives you this point. So now we focus on this FGR, madam. So now the first question which we will ask you, how will you proceed now when we have made a diagnosis of FGR in the setting of reduced fetal movement, where there's a discrepancy in the fundal height and period of gestation? So how will you proceed with this patient?
First of all, we will, as we have done the clinical examination, we will look for any risk factors by maternal previous histories, maternal present condition, maternal medical disorders, and we will we will try to rule out the etiology by saying, is there any major risk factor or minor risk factor? Then we will confirm our then we will confirm the exact menstrual gestation.
Vandana, did you find any risk factor in history? Yeah, Vandana, may I
There was a
interrupt?
previous history of fetal in our
History of
previous
previous
growth restriction. Yes, ma'am.
So that is a major risk factor or minor risk factor?
Ma'am, that is a major risk factor.
Yes, that is one major risk factor. Any minor risk factor was present in your history? Any other risk factor? No. Patient is 29 years old, so that is not a risk factor.
Not a risk factor.
There's no history of preeclampsia, diabetes, or any other medical disease. She is not a smoker. And
But patient is from low socioeconomic status, so she may not be having less intake of
nutrition.
fruits.
She was malnutrition.
Malnourished. So nourishment may be the issue. The less intake of fruits may be coming into the minor factor. Continue.
Just one more issue. In the history, you did not explore as to why she did not opt to stop her family with two.
She used in her after a second cesarean section, she used barial method of contraception. We counseled her, so she went for barrier method, but she didn't go for permanent sterilization.
Mhm.
Her
Because
So she
second
used
pregnancy
for-
was also managed in your hospital, right? Second pregnancy.
Yes, ma'am. Second cesarean was done in our hospital.
so is PPIUCD not inserted? Because it's very safe even after 2 cesareans.
Actually, in our setting, usually patients, we counsel patient for PPIUCD insertion, but she usually wants for injectables or for hormonal pills.
Okay. Go
So
ahead.
she agreed for injectables, and then she went for oral contraceptive.
The question which was asked to you is that what to do once you have checked
Yes,
that your
ma'am.
patient is at, how to proceed
Yes, ma'am.
where
Then
you're standing at 36 weeks with decreased fetal movements. The question was this. Risk factors, evaluation of risk factor will come once a patient will come in an
Yes.
early gestation where you are able
At
going to
36.
evaluate. In this particular patient, she is already third gravida. You're going to do tubectomy with this patient. So evaluation of risk factor it is required as far as academic purposes is concerned, but not for the management point of view is
Yes,
concerned
ma'am.
in this particular patient.
At
Okay.
36 weeks, yes, ma'am. At 36 weeks, we admitted her in view of her previous history and present clinical findings and ultrasonographic findings. And we do daily clinical examination. We did ultrasound biometry twice weekly, clinical examination daily, and NST and biophysical profile scoring.
Vandana, you admitted her at
Video stop.
But Gauri, your voice is not coming. Your video is stopped. Hello.
Can you stop the sharing the screen because presentation is over, I think.
Okay, sir.
Yeah, please stop this. Yeah. Yes. Now you can continue.
tell me, Vandana, what period of gestation did you admit her?
We admitted her at 36
6
weeks.
weeks, right? So where is the question of bi-weekly monitoring from here on?
No, ma'am, we didn't do
That's what you said.
bi-weekly
So how we are
monitoring.
going to monitor? You have admitted, agreed.
We did clinical examination daily and a weekly NST and biophysical profile. And ultrasonography biometry was done at the interval of 3 weeks.
No, Dr. Bandana and Dr. Preeti, we wanted to clarify. We wanted to have your clear concept. First, she's 36 weeks now, right? Now, if you're suspecting FGR, at what POG you will terminate her pregnancy? What is your plan for that? Just tell me first this. So for how long you want to continue with this pregnancy?
If it is mild, then we can continue up to 37 weeks.
37 or 38, right? So that is one point. Second is, depending on your investigations regarding decreased fetal movement and ultrasound of FGR, you may have to terminate early also, right? So, yes. Madam, and we all are asking you, how will you do this? Because if you say weekly or bi-weekly, we don't have that much time. You should, once you have planned that 37 weeks, so we don't have much time to do that many exercises. So you should have a clear concept that when and what you will do.
So let us start again. Today she's 36, you have admitted. What do you do now?
Based on her Doppler findings of umbilical artery and middle cerebral artery, we will decide the timing of delivery. If there is absent diastolic flow in umbilical artery, we will terminate her at 38 37 to 38 weeks.
Which stage is the FGR? If it is absent end-diastolic flow?
Ma'am, it is stage 2.
Then what are the recommendations?
In 24. Monitoring should be done. 37 weeks per termination should be done, and monitoring should be done at.
I don't agree.
Uh,
It is too much to lose, in 1 week's
Hmm.
time. What was the expected baby weight on scan?
It was 2.8 kg.
2.8 kg. Don't you think such a
Ma'am, no, ma'am. It was 1.75 kg.
1.8 kg.
1.8 kg. Yes.
Okay, 1.8 kg at 36 weeks with absent diastolic flow. I don't think there is any role of conservative management. That's my take on it.
She's already 36 plus
Yes.
1. The baby should be out.
Yes, absent
And
diastolic
this
flow.
is this is what you have done all actually. See, there was hardly any time for you to do anything. If this patient would have come earlier to you, then definitely there was some scope for monitoring or for taking her to some level. She is already at the verge. Already baby is mature enough to be taken out. Okay. Otherwise, if she would have gone to 33 or 32 weeks, then the story would have been entirely different. But she's already 36 plus. Okay. So, in any way, do you know what are the stages of the FGR and how to manage them? Various stages, which has been given very clearly. Because now FIGO article is there, and then RCOG, then ACOG, they have given very clear guidelines. And I think all of us should paste these guidelines in our labor room so that we're not able to manage the patients nicely.
They are
What is it?
Barcelona
Stage one.
classification,
Hmm.
in which FGR is classified into 4 stages: stage 1, stage 2, stage 3, and stage 4. In first, there are no umbilical artery Doppler changes. In second stage, there is umbilical artery pulsatility index more than 95th centile. And there is presence of end-diastolic flow. In stage 3, the umbilical artery, there is absent umbilical artery pulsatility index. And in stage 4, there is reversal of umbilical artery.
No.
There in
No, dear.
No, you are going
No,
one
dear.
you're lagging by one
Stage
stage.
2, there is absent in diastolic
Yes.
flow. In stage 3, in umbilical artery. In stage 3, there is reversal of in diastolic flow in umbilical artery. And in stage 4, there is reversal of in diastolic
Ductus
flow in
venosus.
ductus venosus.
Anyway, so let's start from the point A. How do you define FGR? Let's go back there.
Yes, ma'am.
How do you define FGR?
FGR, when fetus fails to reach its genetic growth, FGR is a pathological condition in which fetus fails to reach its genetic growth potential for a particular period of gestation, irrespective of weight, irrespective of fetal size.
Anything else?
And associated Doppler changes are seen, which differentiates it from SG.
Because it is very because latest it has been shown that it is very difficult to tell anything that what is the potential of the growth, because it varies from so many factors. So now they have given one more definition, which is
based
more
on yes, ma'am. Based on biometry, estimated fetal weight or abdominal circumference less than 10th centile, then it is a case of, or if it is less than 3rd centile, then it is a severe FGR.
good. So this is one which we nowadays we're following. So it is basically the 10th centile or less than 3rd centile, because 3rd centile is slightly better to do, because then less number of falls FGR will be detected. Hanji, anything else? Next. What are the risk factors, major and minor, which I think we have covered a bit of them.
Yes,
Can you
ma'am.
repeat them?
Yes, ma'am.
Minor risk factors are maternal age more than 35 years, poor less pre-pregnancy weight, smoking with 1 to 10 cigarettes.
What do you mean by this?
Yes,
What do you
ma'am.
mean by this less pre-pregnancy weight? How do you define it? properly?
If BMI is less than 20,
It is normal.
it's a minor risk factor, ma'am.
And no. Next.
If she is a smoker and she took 1 to 10 cigarettes per day, then it will be a minor risk factor.
Mhm. Quickly. Quickly.
Undernutrition,
Quickly. And major ones. Quickly complete them, please.
yes,
It's
Major,
very simple.
major ones
major-
are more age more than 40 years. Number of cigarette smoking 11 per day. Severe preeclampsia. History of previous stillbirth or history of previous SGA.
Anything related to pregnancy interval?
disorders, some medical disorders like diabetes with vasculopathy, then renal disorders, cardiac disorders in mother,
Infections.
or infection, undiagnosed APH, undiagnosed vaginal bleeding.
In the history, do you want to know about the birth weight of mother or father?
Yes,
do
ma'am.
they have-
Maternal. If maternal SGA, then it is a major risk factor, and if it is paternal SGA, then it is minor risk factor.
Minor risk factor. Yes. Anything else? Because your patient is with you for the third time. She has delivered with you in the second time where
We
she was
will-
diagnosed.
Yes.
Where
We
she
will
was
also go
diagnosed.
for serum marker. We will do pregnancy associated plasma protein A, which if less than 0.4 multiples of meridian, then it is a major risk factor.
Okay, good. So this patient came to you in the first trimester.
Yes, ma'am. We advised her for PAPE, but she didn't turn up at the exact time.
Okay.
For
Ma'am, आप पूछिए. Dr. Gauri. Hello. Dr. Gauri. Dr. Archana.
Yeah, tell me the causes of FGR. It's a very basic question.
causes.
Causes are, we can divide causes in the 3 categories. It can be maternal, fetal, or placental.
So
Maternal-
just quickly specify the under those categories.
Maternal age, undernutrition, any medical condition like hypertension, diabetes, or any history of high blood, any history of severe hypertension, preeclampsia. These are associated. Any maternal infections or fetal infections can be chromosomal anomaly.
So in maternal disease, autoimmune disorders, and in diabetes, you have to say long-standing diabetes with
Long-standing diabetes with vascular associated with vascular disease is more associated with.
Then fetal causes can be due to chromosomal or infective causes like TORCH, toxoplasmosis, rubella. In maternal, there can be infections like malaria if she is living in endemic areas. Then placental causes can be due to placental abnormalities like chorioangiomas of placenta, circumvallate placenta, and low-lying placenta or placenta abruptio.
Filamentous insertion of the
Filamentous
cord.
insertion of cord.
All of these things matter. Okay.
So in fetal causes, anything else like chromosomal disorders?
Yes, most common association is with trisomy 18, then 13, and then 21.
And there could be some inborn error of metabolism also,
Yes.
genetic causes. Okay. So
Ma'am asked you about the relationship. Ma'am asked about the relationship of the interval between the pregnancies.
Less than, if pregnancy is either less than 6 months of duration or it is more than 60 months.
So in
Yes.
this patient, you have got a more than 60 months. Our
Yes.
second child is about 7 years old. So
So
this is
that
again
was one of the risk factor. That was
risk factor for this patient.
yeah.
Hmm.
And
Yes, ma'am.
history of
Okay.
previous FGR plus this risk factor. Yeah.
So 2 risk factors you're already having. Plus she is also a small, I think, small frame girl. She is only 150 centimeter
150 centimeters.
and her BMI is, I think, about 22 or something.
22.22.
22.2. And I do
Yes,
not
ma'am.
know about the father. I think that should also be recorded about the father. That what is the BMI of the father also. Only then we can have a plan whether it is an SGR or FGR. Okay. So if suppose this patient would have come to you in the first trimester and agreed to you whatsoever you were telling to her. So at that time you would have listed, because you or somebody else has put her on the aspirin, nicely done. Suppose she comes to you at about 20 weeks, same patient. So will you advise her to take aspirin?
No, ma'am.
No, aspirin is effective only if it is started before 16 weeks.
And if somebody says that no, I want to give low molecular weight heparin because it is very good.
Yes,
Yes.
we can start low molecular weight heparin.
What is the evidence?
Associated with vascular disease.
No, what is the evidence for FGR?
No.
No,
All the studies they have shown that there is no role of
No
low
role
molecular
of-
weight, no role of it.
no.
Aspirin has got definitive role, so low
Definitive.
molecular weight should not be started as such until unless you have got a definitive
Until
indication for that. Only for
Indication if
FGR
that-
it should not start it.
Yes.
Okay. Okay. Hanji ma'am. Dr. Archana, please continue.
So how will you predict FGR? Like one is history of risk factors we have done. What are the other things?
By
By
biometry, risk factors, then we will
clinical
History
examination.
is the risk factor, then clinical examination,
clinical examination.
serial measurement of symphysofunnel height.
If less than discrepancy of 3 centimeter, then we suspect FGR.
Fundal height. Liker, there is
Is
liker,
there any
less
role of
liker.
serum alpha fetoprotein?
Yes, ma'am. Serum alpha fetoprotein
also.
will be raised.
Raised is not the answer. You have to tell me, like in terms of multiples of median. What then? 2.5 multiples of median. That could be one of the predictor of FGR. Okay.
Yes, ma'am.
Then you have to tell about the ultrasound.
Yes, ma'am. After clinical examination, when we suspect FGR, then we will advise ultrasonography for confirmation of diagnosis.
Most valuable is
For
abdominal
confirmation
circumference.
diagnosis and also for management, like how
Yes.
long you're going to continue, how you're going to monitor. So ultrasound has got role not only in the diagnosis, but very important part in management, deciding the management.
Yes, ma'am.
So how frequently you will monitor through ultrasound? And when
3
will
to
you
4
start?
There should be a minimum of 3 weeks intervals for ultrasound biometry to not to overdiagnose the fetal growth restriction. There should be minimum 3 weeks interval.
But at what gestational age you would like to start monitoring if you suspect FGR?
From 28 weeks onwards.
24 to 20.
By ultrasound, for Doppler, we go uterine artery Doppler at 20 to 24 weeks, and umbilical from 26 to 28 weeks, if it is Doppler ultrasound.
No, but you have to decide whether the FGR is early onset or late onset. There is not one
that
single
will depend
answer.
upon-
There is no one single
It depend
answer.
upon early onset or late onset. So
Ah.
can you just tell me what do you mean by these two terms?
Early onset,
FGR.
yes, ma'am. Early onset occurs in less than 32 weeks PF gestation, and late onset is more than 32 weeks of PF gestation. In early onset, the causes are intrinsic. Usually, the cause is infection, any chromosomal cause, And in this, the baby is symmetrically small. And its management, its prognosis is poor. The ponderal index is normal, but there is no brain sparing. In late onset, it occurs due to uteroplacental insufficiency causes like preeclampsia. And in this, the baby is asymmetrical. The ponderal index is low. The baby has a good prognosis compared to early onset. And there is a cell number is constant, but there is cellular cell number is constant, and cellular growth is decreased in late onset.
Which is more common, late or early onset?
Late onset is common. It is 80. It is seen in 80%, and early onset in 20.
Which is easy to manage?
Management is easy for late onset, but yes.
And diagnosis?
Diagnosis is easy for early onset.
Yes, very important. So early we can diagnose in an early form, but difficult to manage because some pathology is lying somewhere which we may be able to treat or help, or we may not be able to help.
Yes.
So in your patient, it was a late onset FGR. Hope so.
Yes.
Hope so, because
Yes.
Because we don't have a growth chart in this particular patient. We have got only one single reading, snapshot reading, so we cannot say whether it was late onset, because the way the baby has shown the absent end diastolic flow is not very good sign. It means that the baby was compromised for a long time. That is why now that baby has responded like this, okay, bye, I'm going, or help me out. So it's because she was not properly supervised. So suppose your patient, you said you told something about the Doppler of uterine artery, you were just telling me.
Yes.
What do you know about it?
In uterine artery Doppler, we usually see two things. If there is diastolic notching, and whether it is persisting for whether it is persisting in later gestational age, and second parameter which is pulsatility index. Usually pulsatility index would decrease, but if it is more than 95th centile, then we suspect FGR, and we go for umbilical artery Doppler at 26 to 28 weeks.
You just tell me about uterine artery. If somebody asks you, doctor, I want to do right
Yes.
side, right side, left side, or both side, what do you say to that person? What is the recommendation?
Both side should be done. Right and left, both side should be.
Some people say that you do on the side with the placenta is attached. You do it only that particular side. No need to do on the another side. So what are the recommendations? So recommendation is do on the both sides and take the mean.
Both sides, yes.
Mean, yeah, you
Okay,
have to
and
take the mean.
take the mean of them. Okay.
Mean of them, yes.
So, okay. Do in all the, okay, this uterine artery notching or percentile more than 95 is going to give you some clue that this baby is maybe having FGR in the later ages.
Yes.
If you have got, there is a something like in which you are not supposed to do uterine artery, what are those conditions? They say that you go directly to the umbilical artery. Is there something, some criteria has been fixed up? It is from the major and minor criteria. They have taken some guidelines from that you don't do unnecessarily, don't waste your time.
If there are more than equal to 3 minor risk factors, or more than one major risk factor, then we will go for uterine artery. If it is not, then we will do
directly for umbilical artery.
Umbilical artery.
You just skip it, because they say no need to waste, because already risk factors are there. So why to unnecessarily waste your time? Because in government hospitals where we are working, we can get it free. But in private hospital, they do have to pay money out of their pocket. So every doctor is going to charge about few thousand rupees. So that is what we have to tell to the patient. So, okay. So in the first trimester, you have checked all the investigations, basic, and you just tell me the basic investigation which you will order to any female, or especially to this particular female. The first trimester, she has come to you, and she says that my dating is correct, and she is sure of her dates, and she is already having high risk factors also. List of investigation that you would give.
We
to.
will first do all the routine investigations of pregnancy, like complete blood count, her routine examination of urine, her blood grouping, her viral marker, and then her blood sugar by oral glucose tolerance test. Then in this case, we will also advise her to go for PAPE and torch infection serology. For this case, we will additionally advise her for PAPE testing and torch serology.
Torch, Dr. Ashar or Dr. Gauri, do you agree with me?
No, torch I don't think is
It's not
indicated.
required.
Unless you think, see, even if the second baby
Uh,
had suggestion of torch after birth and needed treatment, even then the body would have cleared the infection.
uh,
Truly, it is not needed now in the third pregnancy to look for this as a cause. Unless on scan you find that this fetus is affected by
Huh.
certain
If
causes.
by
Only if the baby is having
And you're
the
having treatment in utero. Otherwise, it's of no use.
polyhydramnios.
um,
Only in those cases CMV will
in those
be
cases we will
done. Otherwise, there is no need. Okay.
yes.
And there is no need to do unnecessary APLA or hi-fi test. There is no need for those investigations. Okay.
Yes,
ठीक, fine. Hanji ma'am, please continue. Dr. Archana, Dr. Gauri, please continue.
Yeah, now I just want to know now, we are having only 4 or 5 minutes for this case. Now let's finish off with so she is a case of previous 2 cesarean. So you're delivering by cesarean only this case?
yes, sir.
Yes. So what precaution or what are the problem you will face during cesarean in this patient?
As it is a case of previous 2 cesarean, then there can be during cesarean we can have low-lying placenta.
So that you should have ruled out beforehand.
That
We
should
have
have been
ruled out before.
and one more very
We
important
have
condition.
localized by ultrasonography. There can be adhesions on opening, dense adhesions can be seen. As our patient is not in labor, so in this patient lower segment is not properly formed, so there will be more bleeding during cesarean section.
So before cesarean, would you like to do something for improving maturity? You're planning an elective.
We will give her one course of dexamethasone corticosteroid course, and yes, ma'am. In this case, we will give only corticosteroid dexamethasone.
There might be, ma'am, some gray area in this because some people
because
may like
it's
to
already
give,
36
some people,
weeks.
yeah, some people may not like to give because it is already
Because
you
all
are
the
doing
recommendations
cesarean.
are changing
Blood is
at-
less than
No,
30.
and they told they will plan cesarean if everything is normal beyond 37 weeks, or if they want to do it now also, she's crossed 36. So probably steroid may not have, all may not agree with that. So it is now comes to the individual variation, whether you want to give steroid or you don't want to give steroid, right? Okay. Then anything more? She's a previous 2 cesarean. Anything more
We
you want
will
to
ask
counsel the
her
patient?
for, yes, ma'am. We will ask her to keep arrangements for blood. There can be
Okay.
more.
What else? What about contraception? Will you discuss the patient
We will
about her
counsel
contraception?
her about contraception. We will counsel her
Yes.
for permanent sterilization.
Yeah. So these are the few things which are there in between. You have to know about your case and discuss. Any query or any more points? Anything from our faculty or from seniors? Then otherwise we'll move on to the second case now. Any Dr. Sarita or Dr. Rajesh, you want to ask something from them? You can unmute and you can ask. And if there are any comments from the audience, from my students, you can put it in the chat box. We'll try to answer them.
Dr. Preeti, suppose during the cesarean section, bladder is abdominal wall, there are a lot of adhesions. You cannot open the peritoneum. So how will you manage? You're opening the abdomen, your rectus sheath you open, and after that, everything is stuck. So is there any clue or how will go for the section? This is quite common. Previous to LSS is quite common. So basically, you try to go as high as possible. You try to open the peritoneum as high. Dissect the rectus sheath away, some more, 2 or 3 centimeters away from that. And then you try to open as high as possible, because you don't know where is the bladder. Once you open there, you'll be getting some window there. Once you open that window, then you can start adgiolysis. You can cut the adges and then come to the lower segment. So that is a clue. Always it should be higher up. Open in higher up. Don't open in the lower up, because there are high chances of opening the bladder.
Yes.
Okay.
I just want to ask you, will you clamp the cord early or late in this patient?
Early cord clamping is done in growth restricted babies.
Because you don't want to lose the blood. And how much will the length of the cord you will leave with the baby?
We'll keep the length longer.
How long?
Why? Longer? Why? And why?
And how long?
10 centimeters. 4 to 5 centimeters.
What is the normal length of the cord?
10 centimeters.
Normal length.
14 centimeters.
It is 50 centimeters, but
50.
50.
Right.
And the cord which you will leave with the baby in such cases will be 10 centimeters
10
or
centimeters.
more, because if your baby may be needing some manipulation, so which can be done. Okay.
Yes, thank you.
And obviously there is a question in the chat box. So obviously before doing this thing and ultrasound we always localize placenta, and in previous cesarean we always rule out morbidly adherent placenta. So that is a routine nowadays. So there is no question that we will have a surprise. We always try to rule out all these things in the pre-operative period. Okay, so thank you very much, Dr. Hafiz. We can move on to the second one. Yes.
Yes, sir. We'll move to the second case.
Thank you.
So thank you, students.
But I request my faculty to stay back and give your inputs for the second case too.
Yeah, please, all the faculty should. And thank you, Bandana and Preeti, for your nice presentation and participation in the discussion. So I hope this will give you lots of in future confidence as well as in patients. So next case is thank you. Next case is from the students of All India Institute of Medical Sciences at Raipur. So Dr. Farhad Jahan Khan and Dr. Akriti.
Good afternoon, everyone. Good afternoon, everyone.
So please start sharing and presenting. Is there an issue?
Sir, can you see my screen?
Not yet. Yeah, now it's.
Yes, now we can see.
Okay.
Put it in slideshow.
Yes, ma'am. Just a second.
Good afternoon, Dr. Ashok Kumar, Dr. Hafizul, Dr. Gauri, Dr. Rajesh. Nice to see everyone.
Yeah, good morning, everyone. Yeah, good morning. Welcome to all my Dr. Sarita and Dr. Rajesh for this program. And thank you for sparing your valuable time.
Thank you. Thank you.
Thank you for inviting us. Are we good to go?
Yeah, ma'am. Is the screen visible to everyone?
Yeah, it's visible. Please go ahead.
Thank you, sir. Good afternoon, everyone. Today we are going to do a case presentation on recurrent pregnancy loss, which will be presented by myself, that is Dr. Farhad Jahan Khan, and my co-PG, Dr. Akriti Singh. We are third year PG residents of Department of Obstetrics and Gynecology, AIIMS Raipur. Patient particulars. My patient named ABC, aged 33 years old, 12th standard by education and supervisor by occupation, wife of Mr. XY, who is aged 32 years and he is LLB by education and works as a lawyer. She is resident of Mahoba Bazaar, ward number 13, Tatiband, Raipur, Chhattisgarh. She is Hindu by religion and she comes under socioeconomic status scale class 2 according to modified Kupuswamy score, which is upper middle score, based on her total score of 19, which was calculated based on occupation and education of the head of the family and total income of the family. Her obstetric score is G5, P1, A3, living issue is 0 and IUD 1. She presented to us at period of gestation 8 weeks plus 1 day and date of history taken was on 6 December 2022. History of presenting illness. The patient was apparently well 2 months back when she had missed periods for 2 months, her last menstrual period being on 10th of October 2022. She had complaints of nausea for 1 month, which was not associated with vomiting and it occurred mostly in morning hours. She also had complaints of dizziness on and off on getting up from bed for 1 month. The patient also complains of slight breast discomfort for 1 week. She visited AIMS OPD with the chief complaint of history of amenorrhea for 2 months and nausea and dizziness for 1 month. On taking detailed history, she had no history of increased frequency of micturition, fatigue, bleeding or discharge per vagina, pain abdomen, fever with rash, or any history of suggesting exposure to teratogens, that is drugs or radiation. Her pregnancy was a spontaneous conception and it was confirmed by UPT, which was done by self, followed by which she visited AIMS OPD and a scan was done 2 days back, that is at 8 weeks. Then she also gives history of starting of tab Ecosprin 150 mg and folic acid 5 mg, which was started preconceptionally for last 4 weeks and she's still continuing to take it. She had done her first scan at 6 weeks POG and then on 4th December, she repeated her scan. And according to patient, it was suggestive of normal intrauterine pregnancy with cardiac activity present and no obvious uterine anomaly. She had been started on injection enoxaparin 0.4 ml SCOD since her dating scan. As per patient, all her routine investigations which she had done at her first visit were, that is CBC, blood group. As per patient, her blood group was O positive, sickling, TSH, NTT-pure, HbA1c, OGTT, RPR, and viral markers along with urine culture and sensitivity were done and were normal. Coming to her menstrual history, her age of menarche was 14 years and her past menstrual cycles were regular of 24 to 26 days with average flow of around 5 days associated with mild dysmenorrhea. Her LMP was 10th of October 2022 and her expected date of delivery was 17th of July 2023, which was calculated according to Naegeli's formula. And based on that, her period of gestation as on 6th of December 2022 was 8 weeks 1 day. In her obstetric history, her married life was 4 years and it was a non-consanguineous marriage with her first pregnancy, which occurred after 3 months of marriage, that is at age of around 29 years. It was a spontaneous preterm vaginal delivery of IUD baby at around 30 weeks of pregnancy in February 2019. In her first pregnancy and in first trimester, she had taken tab folic acid and first dose of injection tetanus TD at the end of 2nd month of period of gestation with 1 USG at the end of 3rd month, which according to the patient was reported normal. She had history of mild nausea, vomiting, and some increased frequency of micturition, but she doesn't give any history of fever with rash, bleeding per vagina, or any history of drug exposure, radiation, or acute illness. In this pregnancy, she had, I can't see the full screen.
Has she lost network?
No, my network is visible. I cannot see the initial screen actually. In this pregnancy, she had 1 USG done at the end of 3rd month of period of gestation, and according to the patient, it was normal. In 2nd trimester of her first pregnancy, she took iron and calcium tablet, but there was no any history suggestive of any acute illness. In her last trimester, there was no history suggestive of preeclampsia, antepartum hemorrhage, anemia, or any other illness. But at around 7.5 months of period of gestation, she had complaints of failing to perceive perception of fetal movements, which was followed by pain in abdomen, which were probably labor pains, and then altered color bleeding for after about 1 hour of pain occurred. Then after 2
One
hours.
sec, can I just ask you something here, that between the 3rd month of pregnancy sonography and the 7th month, there was no sonography done?
No, ma'am. No, ma'am. She didn't get any other investigations done.
So do
She
you
had just
think
one,
that any
like,
sonography should have been done?
Yes, ma'am.
Why?
Definitely have been done second trimester. Early anomaly, according to the patient, she had done early anomaly actually.
No, according to the patient, you
Detailed
said she had
anomaly should
done
have been done.
early anomaly scan. What is early anomaly scan and late anomaly scan? And what is anomaly scan?
Ma'am, in early anomaly scan, a scan is done at 11 weeks to 13 plus 6 weeks period of gestation, in which we check for nuchal translucency.
But does that mean that you don't do an anomaly scan later?
We will do definitely do anomaly scan later, ma'am.
Okay, go ahead.
Okay, in a third trimester, at around 7.5 months of period of gestation, the patient had complaint of absent perception of fetal movement, which was followed by pain in abdomen and followed by altered color bleeding per vagina after about 1 hour of onset of pain. Then after about 2 hours, the pain increased and she delivered a dead fetus, and which according to the patient had genitalia of male. As per her, the baby was normal looking, no skin peeling, no gross abnormalities were noticed. It was a home delivery with no excessive bleeding complaints and no history of postpartum fever or any other complications. She didn't take any medical care after that. Her second pregnancy, it was a spontaneous abortion at around 10 months of POG. That is, in patient's word, it occurred at around 2.5 months of POG, which occurred in June 2019. Her pregnancy was confirmed by urine pregnancy test after 10 days of periods overdue by self. She doesn't give any history of fever with rash, bleeding per vagina, any history of drug exposure, radiation, or acute illness. She had not taken any antenatal care in this pregnancy, and then she had noticed a sudden onset of cramping, lower abdominal pain, followed by dark colored vaginal bleeding, and used 2 to 3 pads partially soaked per day. And around after 2 to 3 hours of her bleeding, she expelled a big clot, unable to tell the size. I tried to elicit the size, but she could not tell. And she is telling that it was a fleshy mass-like structure. The bleeding persisted for around 3 to 4 days, for which she visited a local doctor where USG was done, and she was told that she has aborted completely. So no evacuation was done, and she was advised some medications and blood tests. However, the patient did not get any blood tests done. Her third pregnancy was in 2020 October, and it was also a spontaneous abortion at around 10 weeks of period of gestation. Her pregnancy in this also was confirmed by UPT at home after 6 weeks of last menses. It was a spontaneous abortion at around 10 weeks, which in patient words was around after 2.5 months of her last LMP in June 2019. Her pregnancy was confirmed by UPT after 10 days of periods overdue by self. No history of fever with rash, bleeding per vagina, any history of drug exposure, radiation, or acute illness. The patient complains of sudden onset of cramping lower abdominal pain, followed by dark colored vaginal bleeding again, and around after 2 to 3 hours, again the same pattern was there, that she had complained of bleeding and expelled a big clot. And in this also she was unable to tell the size.
1 second. Now here, was any sonography done?
No, ma'am. Again, she hadn't done.
Is it important?
Yes, ma'am. It's definitely very important based on the previous histories.
Why is it important?
Ma'am, if he's like if it is coming of recurrent spontaneous abortion, like 2 times already, she one time preterm IUD was there, and second time spontaneous abortion was there, and then third time to rule out any anatomical causes, uterine anomalies, and to confirm if the pregnancy was intrauterine or not, and whether it was the pregnancy had any cardiac activity or not, or it was embryonic, if the embryo was formed or not.
Why is that important?
Ma'am, to reach to the diagnosis that why she is having recurrent abortions, ma'am. That's what I'm telling. If she would have done.
What will you think of if it is anembryonic? What will you think of if there is cardiac activity?
Ma'am, if it is anembryonic, then most probably it may be genetic causes, chromosomal anomaly or any translocations are there, or probably it is suggestive of that. And if it is, if after cardiac activity is present and then she is losing pregnancy, then it may be mostly due to autoimmune causes or endocrinological causes or due to some infections or yeah,
Let us,
yes, ma'am.
a couple of things in your history.
Yes, ma'am.
Let me, since we have started the discussion because it belongs at this point of time.
Yes,
In your
ma'am.
first history itself, there are a couple of things that you should bring out when she had stopped perceiving fetal movements. Whether she had a fever preceding it. Second, you are talking about that she had about 1 hour of bleeding after the pain, right? And
Yeah.
then she expelled. So was it a possible abruption? Because it also seems to have been very quickly that she went on to expel that fetus.
It
Okay.
could be possible abruption, ma'am, but she is giving history of altered color bleeding.
Yeah, altered color bleeding is common in abruption, which is a slightly older abruption, because you don't get a fresh bleed in abruption, isn't it? Now,
Yes.
given this, how was the postpartum period? Whether she developed anything suggestive of deep vein thrombosis is very important to also unravel a possible underlying problems. So
Yes,
you
ma'am.
need to specifically bring it out as a negative history.
Okay,
Don't
ma'am.
say it is negative, so I will not talk about it.
Sorry, ma'am, to interrupt. Ma'am, just I wanted to ask, I've written ki it was home delivery with no excessive bleeding and no history of postpartum fever or any other complications. So I need to specify.
You
In
saying
com-
any other complication is wrapping it up. You have
Okay,
not
okay.
explored that the patient had history. There is no history suggestive of swelling in the legs with pain. It is possible she may not have come to a doctor.
Yes,
She must
ma'am.
have disregarded or she must have walked around and it might have resolved. I don't know. But
Yes.
by bringing this specific history, you are trying to look at an underlying, we all
Cause.
know Aplar syndrome as a possibility.
Yeah, yes, ma'am.
Similarly, in your second and third pregnancy, you have to see history is not to be presented by you as what patient narrated to you. You have to apply your interpretation. So you have to mention patient never got a scan done. That's what madam asked you. Was a scan done or not? If you had given this information, we would not have asked you.
Yes,
Get the point?
yes, ma'am.
Patient never got a scan done.
Yes, ma'am.
Right? Because at this juncture, can you now tell me what do you understand by early pregnancy loss and how do you classify them? Because history taking is all that matters in a case of bad obstetric history. Before we go on to decide which investigation to choose.
Should I narrate about early pregnancy loss?
Yes. How do you define how do you classify the early pregnancy loss? Because lot of etiologies will come out of it.
Yes, ma'am. Early pregnancy loss, ma'am, it occurs due to if any pregnancy loss occurs in first trimester, then it is considered as early pregnancy loss, and it has been classified according to etiology based on genetic causes, anatomic causes.
No. When we talk about early pregnancy loss, there are 3 varieties. One is an embryonic one.
We can say ectopic pregnancy, molar pregnancy, or intrauterine.
No. We are talking about intrauterine pregnancy from the etiology of first trimester losses. One is anembryonic.
Anembryonic. Okay.
When you just don't see an embryo. And
Then
then you saw an embryo, but there is no cardiac activity ever since conception, which is called as embryonic.
I think madam means embryonic loss and fetal loss. So what is the difference between an embryonic loss and a fetal loss?
Ma'am, till 5 weeks to 9 weeks, an embryo is considered, and after 9 weeks, fetal loss is there. Matlab, after 9 weeks, if the cardiac activity is present, then that embryo is said to be fetus, still intrauterine.
Yeah. 8 weeks. I think Dr. Gauri, you lost connection for a second in the middle. Yeah, go ahead, please.
Yeah. So the second thing is you need to know, is it an embryonic loss or is it an early fetal loss or a late fetal loss? That means anything less than 12 weeks or beyond. Every aspect of these 4 aspects have different etiology. I'll give you I'll ask you a question. A patient has repeatedly something suggestive of delayed periods. Right. That means she missed her cycle, she did a UPT, next day she had a normal periods. Within 3-4 days of her pregnancy test positive, if she develops something like the pregnancy does away and it is like a delayed periods, what are the etiologies there?
Ma'am, it can be a blastocyst, implantation bleeding.
So it is an implantation failure.
Presentral implantation, Hartmann cell.
And then it can be missed abortion also, or it can be missed abortion.
Abortion word is actually done away with because missed abortion by definition is something which was retained inside for 8 weeks.
Okay.
So now it has been reassigned as early pregnancy loss and assigned into these etiological differentiation. So when you have an implantation failure, the history would be that the patient missed her periods, 3-4 days she did UPT, she started bleeding, she thought and that's it. So for that, what is the causes?
Implantation failure, ma'am, it can occur in various causes. Anatomical causes are very common in implantation failure. Like a fibroid is there, or adenomyoma is there. Fibroid.
No, they are very, very rare causes. Recurrent implantation.
Intrauterine adhesions are there, ma'am.
Will point towards the septum. More often a septum.
Septum.
And there can be intrauterine adhesions, agreed. But fibroid adenomyosis is not very common at all.
Yes, ma'am.
They end up in preterm labors rather than implantation failure. Similarly, endocrine causes, thyroid disorders, etc.
Yes, ma'am.
Okay. After the implantation failure and progesterone deficiency.
Progesterone deficiency.
This comes the anembryonic causes. So everything is dictated by history alone. You should have specified scan was not done, and if it was done, you have to bring this difference out.
Yes,
that the patient was told that there is something suggestive of pregnancy, but a fetus is not seen, or a fetus is seen but cardiac activity is not there, or fetus had cardiac activity and later, in spite of that, she aborted. Because the causes will straight away change into these three. So, embryonic, you correctly said genetic causes, right? Embryonic causes, that means fetus was seen but never had a cardiac activity appeared.
Yes, ma'am.
What would be the causes for that?
Fetus. Ma'am, it can be due to missed abortion.
Autoimmune is usually early fetal deaths.
Yes, ma'am.
But fetal deaths are there. These can still be an autoimmune problem. So early embryonic.
Is your history over? Has she finished?
No, ma'am. It's not over.
No, because
so can you summarize the positive points quickly?
Ma'am, actually, I need to tell more of the
go ahead.
Gravid actually.
Go ahead.
In her fourth pregnancy, which was in March 2022, there was again a spontaneous abortion at around 9 weeks of period of gestation. In this, her pregnancy was confirmed by urine pregnancy test at home after 4 days of missed period. In this also, she had not taken any antenatal care. No dating scan was done. She had taken TAF folic acid and was advised follow-up after 1 month for USG in a local hospital which she visited near her home. She did not follow up. At around 9 weeks of POG, she had sudden complaints of cramping pain in lower abdomen of moderate to severe in intensity, but there was no complaints of bleeding per vagina. Then she consulted nearby hospital within 1 hour of onset of pain, where she was given some analgesics, but no USG or vaginal examination was done as per patient. The pain subsided, but 4 days later, she noticed bleeding per vaginum during bathing, which was 4 to 5 drops, dark brown in color. She consulted private hospital again immediately within 1 hour of onset of pain, and around after 2 to 3 hours of bleeding, she expelled a big clot. Again, she's unable to tell the size, and she's saying that it was a kind of fleshy mass. There's no history suggestive of fever with rash, bleeding per vagina, any history of drug exposure, radiation, or any acute illness. USG was advised in this pregnancy, but she did not get it done, and she straight away went home. Then she visited AIMS Hospital in September 2022 for pre-conception counseling, where she was advised few blood investigations and USG. According to the patient, her blood report was suggestive of APLA positive, and rest of blood and urine investigations were normal, and USG was also normal as informed to her by doctor. Here she was started on tab Ecospin 150 mg 1 tab and tab folic acid 1 tab daily.
So can you tell us what investigations would you do for a case of recurrent pregnancy loss? First, how will you define recurrent pregnancy loss?
Ma'am, according to ASRM 2017 and European Society, it has been classified as recurrent pregnancy loss has been defined as two or more than two pregnancy loss, which is confirmed by beta HCG either in serum or in urine, or along with one USG or histopathological examination. And according to RCOG, it says at least three or more than three pregnancy loss should be there.
Okay, Dr. Rajesh, would you like to ask something?
So, Dr. Farhat, you said in the history, first was IUD. After that, there were 3 spontaneous abortions.
Yes, sir.
But if there is a first IUD, second abortion, third abortion, in such abortion cases, mostly patient goes very early to the hospital. Even on
Yes,
the fourth also you said patient did not went to the hospital. Straightway 9 to 10 weeks, she had some cramps, bleeding PV, and she went to the hospital. But it
Yes.
normally doesn't occur because patient is more anxious. If she has first loss, second loss, third loss, fourth time, definitely she will go early. The moment our urine pregnancy test is positive or something is there, she will reach early to the hospital. Whether you have elicited that history.
Yes, sir. I have visited. Actually, the patient was at that time living in village at her in-laws. Then she, in her 4th pregnancy, sir, after her periods were overdue and when she tested her UPT to be positive, she went to the hospital and her first USG was as per patient that she was given folic acid and USG was advised after 1 month. But the patient was careless. She didn't visited a hospital again after 1 month. And then when she had complaints of pain and pain, first of all, pain occurred. Within 1 hour of onset of pain only, she visited local hospital, but according to patient, that hospital didn't have gynecology. A male doctor saw her, asked the symptoms, and then she said she didn't say she had any bleeding complaints. So he gave her some analgesics and didn't do any USG or local vaginal examination in patient's words. Then she again visited her hospital when she had complaints of bleeding per vaginum. After like the pain had subsided for 4 days. The patient was like she was again careless enough to not to go. But when she noticed bleeding, like a previous pregnancy loss, then she visited hospital. So in 4th pregnancy, she has visited.
See, if the patient is from remote places, is not aware of sonography, is far away from her CT place, because this patient, according to ST, she is aware of the everything. She is aware of the investigation, she is aware of the ultrasonography, everything.
Yes,
so
sir.
Any patient is having 1 or 2 nowadays patient, at least 1 abortion also patient, they say next pregnancy patient immediately go to the hospital.
Yes, sir. Actually, the patient normally lives in Raipur only, but as soon as she diagnoses pregnancy, as per the patient, her husband takes her to in-laws place, and her in-laws is in village. So she is like unable to access the medical care easily there, as per
And it's
patient.
also possible because it was COVID year, because I saw the
very well possible in her 4th pregnancy.
That could be the reason.
Because that Sarita madam told you, ultrasonography is very important early pregnancy, because you can decide, as Gauri madam has already, you can diagnose and what exactly the cause of that abortion you can make out.
Yes, sir.
So that is very important.
So suppose this patient came to you in the inter-pregnancy time. Let's start with that. What investigations would you do?
If she would have come, like she already visited to us in her inter-pregnancy time only, so, ma'am, first of all, I would have done her blood test, including her hemoglobin, platelet status, blood group. As Chhattisgarh is a sickling belt, I would have definitely done her sickling HPLC, testing for sickle cell disease. Then I would have done her thyroid, which should include at least TSH and anti-TPO antibody. For her sugar, I should have checked for HbA1c and 75 gram OGTT or FBS or PPBS. And then viral markers I would have done, which would include RPR, HIV, HbSAg, HCV, and then urine culture sensitivity, at least minimum. And then USG also, I would have advised definitely a USG for her to rule out any.
Would Akriti like to tell what type of scan would you do for these patients?
For ma'am, for this patient, if the patient is coming with recurrent pregnancy loss, then apart from the dating is preconceptional, to rule out any uterine anomaly, I will advise a 3D USG along with the other blood investigations to rule out any anatomy.
What are you looking for in the 3D ultrasound?
Ma'am, we will look about the shape of the uterus, size of the uterus, any septations are there or not, or internal cavity and any other
Okay, I think you said all the blood reports. What about thyroid testing?
Ma'am, I would
thyroid testing.
Thyroid testing will be done. Especially, we will advise a serum TSH along with the anti-TPO antibodies, because those are more responsible.
Because, ma'am, in studies we have seen even if the patient is euthyroid and if she is anti-thyroid peroxidase antibody positive, then recurrent pregnancy loss cases have been seen. And in this case of euthyroid patients, studies have shown that if we have started like moderate low dose thyroxine, if she's euthyroid TPO anti-TPO antibody is positive and 50 microgram thyroxine have been started, then improved outcomes have been seen, ma'am. So we would have definitely got it done.
Did you mention any autoimmune markers?
No, we should test her for APLA profile, ma'am.
What is APLA profile? Is there a
APLA
profile?
No, ma'am. APLA test, it consists of testing for 3 antibodies, that is lupus anticoagulant antibody. Then second is lupus anticoagulant antibody, then beta-2 microglobulin antibody IgG and IgM, and then anticardiolipin antibody IgG and IgM. Ma'am, it consists of 3 laboratory parameters actually.
So when do you do it? How often you repeat it? Is there any?
Ma'am, we do it with when patients are coming with such history, which may be suggestive of APLA syndrome, like thrombosis and or any previous history of thrombosis, deep vein thrombosis, any history of or any history of abortion. Like in pregnant patient, our criteria is followed: Sapporo's criteria or Sydney's criteria. We get it done. And then if any test is coming positive, supposedly, if lupus anticoagulant is positive, or if beta-2 microglobulin is positive in medium titer, that is high titer, that is greater than 99 percentile, or anticardiolipin antibody is positive in at least in medium titer, that is between, if IgG is between 40 to 50 GPL, or IgM is more than 40, at least in between 40 to 50 MPL, then we say that one laboratory parameter is positive, and we will to confirm this, we will repeat it after 12 weeks.
What is Sapporo's criteria you just mentioned?
Yes, ma'am. Sapporo's or Sydney's criteria is followed for obstetric patients susceptible of antiphospholipid APS syndrome, ma'am. In this, we there should be one laboratory criteria as well as at least one laboratory criteria should be positive, and at least one obstetric criteria should be. And in this obstetric criteria, the Sapporo's criteria specifies that the woman should give any history of at least one spontaneous abortion of more than 10 weeks POG, of morphologically, anatomically, and histopathologically normal fetus, or at least 3 consecutive spontaneous abortion of less than 10 weeks, which after ruling out any hormonal, endocrinological, or anatomical cause, or at least one preterm delivery of morphologically normal baby after 34 weeks of pregnancy due to preeclampsia, eclampsia, or any placental deficiency.
Are there any other criteria related to the mother's history?
Yes, ma'am. Along with the
What
other
if she has
clinical
had
findings,
if she has had a deep vein thrombosis, if she any criteria?
Sorry, ma'am, can you please repeat?
Sapporo's clinical, you talked only obstetric. No, madam is asking, is there any other criteria?
the thrombotic event also we will ask about, like DVT and the any history of any seizures or stroke, transient ischemic attack, or
arterial or venous thrombosis, both. Okay.
Yes. Most commonly deep vein thrombosis
venous
and
is more common.
in arterial.
Okay, so in this patient in intercurrent period, is there any role of doing vaginal cytology for progesterone or looking for luteal phase defect?
Routinely, it is not recommended, ma'am. It's not recommended routinely in guidelines.
But if it is less than 5 nanogram per ml, then it indicates there may be pregnancy loss. So it should be more than, if it is more than 20, value is more than 20 nanogram per ml, then chances of, there may be decreased chances of pregnancy loss.
Okay, going back, if the ultrasound is not conclusive, there is a suspicion, what would be the next step in the intercurrent period?
If the ultrasound is not conclusive, then ma'am, we can go for diagnostic laparoscopy. Diagnostic histolaparoscopy.
Tell us, no? Laparoscopy alone is not enough?
Diagnostic histolaparoscopy, ma'am. Or MRI can also be advised, ma'am.
Okay. So can you answer, madam, once again, what are the other tests you would like to do? We stopped you at ultrasound.
more tests we can do diagnostic histolaparoscopy, and to rule out anatomical causes we can also do SIS or HSG or MRI. For these all are for anatomical causes of pregnancy loss of uterus, ma'am.
Okay, let's stick to anatomical causes. Dr. Darde, I'd like your inputs on this. So first tell us now, we are looking, suppose you find on it on your 3D ultrasound a suspicion of a septate uterus. How would you proceed?
Whenever we are finding any septate uterus, then we will plan for resection of that septate uterus, because after resection, first of all, it can cause recurrent pregnancy loss. So
First of all, ma'am, we will confirm by diagnostic hysteroscopy that septum is there, and if a septum is there, then in that same sitting we will be dissecting that septum, because treatment will be also
Only
done.
hysteroscopy? You will be doing only hysteroscopy?
No, we will be doing, ma'am, laparoscopy also.
Why? Why? Tell me why. Confirm
biconjugate uterus can be there, na, ma'am? Or
exactly. Suppose it is biconjugate, what will you do?
What will you do if it is biconjugate?
Ma'am,
You have to first classify it.
Saline infusion.
Just seeing a septum and cutting is not the answer.
It's not enough, correct.
Mullary and anomalies you have to classify.
Okay.
If you do histolaparoscopy, as you initially said, only hysteroscopy will not suffice. So you have to do histolaparoscopy and find out or confirm the findings of ultrasonography. As Madam said, whether it is a septate uterus, is a bicornate uterus. If it is a septate uterus, suppose it's a broad septum up to the internal os. How will you manage that? It's a broad septum. There may be septum, maybe like narrow septum, and maybe
partial or complete.
It's a partial septum. Now suppose septum is a broad base and it's up to the internal os. So how will you manage that case? And laparoscopy fundus is normal. So that is diagnosed as a septate uterus. So what modality you would like to use for this?
Sorry, sir.
How will you, by hysteroscopically, how will you manage this?
Sir, we will be like using Collins knife and operative channel we will be using, and we will be doing septal resection. If we are unable to do it in one sitting, we will plan it again after 3 weeks, sir.
Will you use monopolar or bipolar?
Bipolar, sir.
Okay, nowadays we are using bipolar. As you correctly said, suppose septum is subseptum or is very small septum, we can manage with a Caesar.
Yes, sir.
Most of the cases can be managed with Caesar. Only if it is a broad septum, it's very difficult because it will take a little long time. Still, this can be managed with a Caesar, but it is going to take a little more time. So if we use cautery and that too bipolar, so there are, why you don't use monopolar in this case? What are the advantages of bipolar or the monopolar?
Sir, monopolar.
Yeah.
Sir, if we are using depending on the distending media also, sir, if we are using monopolar, then we need to use the distending media according to that, and then it has more chances of
media.
Sir, NS.
No, because you are using monopolar, you have to use 1.5% glycine.
Glycine, sorry, sir.
It's not normal saline is used in the bipolar. That's why
bipolar, yes.
you are using 1.5% glycine. So what are the more complications of glycine?
Sir, fluid retention, pulmonary edema, and osmosis.
Hyponatremia.
So how will you detect that during the operation? And which is the best anesthesia for these cases?
Sir, patient will start complaining about pulmonary edema she will develop. So by chest
auscultation,
sudden drop of oxygen saturation will be there. So we can.
If it is a severe case, there will be frothing also.
Repetitions will be present.
This usually can be managed under spinal anesthesia. Okay. And how much loss that is input and output? How much should be the loss to stop the procedure or?
More than 1,000 ml is not accepted, sir. More than 1,000 ml, we have to stop the procedure.
More than 1,000, yes.
Yes, sir.
More than 1,000, you have to
stop
the procedure.
Yes, sir.
Okay, same thing applies even suppose there are, okay, this is for the septum. Small septum, I already told you can use with a Caesar. Or what are the other modalities for using the septum dissection? One is, you said current, then is
Collins,
third.
Collins knife, sir.
Anything else? All the hospitals may not be there. Very high-fi hospitals. I think Sarita madam will agree in Mumbai. They will use that. Laser, we can use laser. But routinely all the gynecologists cannot afford that laser because laser is costly. but that is also one of the way where we can resect the septum. Okay. Suppose you have resected the septum. What is the post-operative management after the patient is going home? What advice will you give to the patient?
First, I'll be putting her on OCPs for deepithelialization, and that will be contraception. First of all, I'll be giving her, putting her on estrogen replacement therapy and Follies,
intrauterine Follies.
or estrabate alone.
All the cases of septum, would you like to introduce Follies intrauterine?
No, sir.
So which are the cases?
Either we can give
estrogen, or we can
intrauterine Follies for 7 days, or we can give estrogen based.
Yes, estrogen post-operative can give estrogen. If it is very small subseptum, there is no need of doing anything. Okay, if it is very broad and there is a lot of adhesions also, we can keep Follies sometimes, or previously we used to keep intrauterine copper T without copper. And that was to remove later on.
What if you found a bicornuate uterus? Is there a role for doing metroplasty with this history for your patient?
With this history of ma'am, we should go for metroplasty because she is having recurrent abortions.
I won't agree. Because usually bicornuate
maybe it is like,
have,
ma'am, it is confusing us. First pregnancy outcome was due to like bicornuate, and maybe bicornuate uterus is existing along with this some other causes which we are confused.
Typically bicornuate uterus causes preterm labor. It doesn't cause
preterm labor. Yes.
Okay, so if there is IUD or abortions in the first trimester, we need to look for other
trimester,
jump to do a metroplasty.
Yeah. Now, what about genetic causes? Is there any investigation you can do
yes,
on the products of conception?
Karyotyping, fetal chromosomal microanalysis can be done, ma'am, and then microarray analysis, and then for parents we can do maternal and paternal both karyotyping.
So let's go one by one. When will you consider doing karyotyping of products of conception?
If it is products of conception, if it is first trimester pregnancy loss, most of the times, then we should, if we are getting the tissue, we should definitely, if it is facilities available, we should do.
After 2 spontaneous abortion, early pregnancy loss, we start
or if the family has history of, if the maternal side or any paternal side, if there is history of any abnormal birth of any abnormal offspring in first degree related, both maternal or paternal, or any mental.
If there is a history of some abnormal child in the family, then you have to have the index case, and you have to know what is the index case. You cannot do products of conception for that karyotyping, can you? That is what is called this Mendelian inheritance. No, it is a gene.
Yes, ma'am.
The other thing is, the problem of products of conception for microarray analysis is the maternal contamination. So how do you circumvent that? Every time you take only the products that she has expelled is likely to have maternal contamination.
Yes, ma'am. Yes, sure.
So is there anything? We always do a microarray. We do not do only a karyotyping. So what else will help? A comparative
genomic hybridization can be done.
Yes.
Whole genomic sequencing can be done to locate specific genes responsible for that anomaly.
Okay, so any other way of approaching for genetic problems underlying other than the products of conception analysis? Which is recommended by most of the bodies. You were at it?
Maternal and paternal, first of all, will get karyotyping done, ma'am.
Yes. Because quite often we may come across subtle things like inversions in the chromosome, etc.
Valence translocation, reciprocal.
Okay, so it is recommended when there is 2 or more abortions. The definition by RCAG alone is 3 or more. All other bodies are recognizing at 2 or above. So we should do the karyotyping as well of the parents. Okay. What is the role of doing torch in this patient? If she had come to you after the 3rd abortion in the intercurrent pregnancy, or now that she is pregnant at 8 weeks, would you do a torch examination for her?
No.
Ma'am, we can do, we cannot, we usually don't do torch testing, but VTRL uses cardiolipin. So there may be false positive VDRL.
VDRL is okay. False positive is there. So if VDRL is positive, what would you do? If you find VDRL positive, what would you do?
RPR testing, I'll confirm, and then
test.
I'll be starting injection benzathine
No,
penicillin.
no. With VDRL alone, you don't do that. No, you have to do a TPHA or something like that.
I will go for
especially false
TPHA.
cardiolipin based investigations could come out as false positive. So it could be a false positive VDRL. So confirm it by another method and then go ahead with the management. Okay. So torch typically does not have much role in a patient with recurrent pregnancy loss like this, right?
Yes.
Now, suppose this patient was APLA positive, anticardiolipin, lupus anticoagulant positive, one or more. Then how would you manage the patient?
First of all, I'll try to confirm my like APLA positivity by repeating the test after 12 weeks, 3 months, and in that period I would not.
Now that's also come positive. Patient is still not pregnant.
So I'll be starting EcoSprint preconceptionally, which has been suggested by most of the guidelines that it has, if it is started preconceptionally, effect of growth pregnancy outcomes have been seen. And once she gets pregnant, ma'am, on confirmation of intrauterine pregnancy, straight away I'll be starting along with injection enoxaparin, LMWH.
Ma'am, first we have to also see that if there was any thrombotic event in the past,
yes,
and depending upon that, if any thrombotic event was present in the past, then we can directly go for therapeutic dose LMWH along with the aspirin.
So my question to you, if there was no previous thrombotic event and she's APLA positive confirmed, can you, instead of giving low molecular weight heparin, put her on warfarin after 14 weeks?
And if according to the guidelines, ma'am, if the patient has previous history of any thrombotic events, then only it is recommended that we start.
Why is it not recommended for pregnancy protection?
Because of teratogenesis, embryopathy causes mostly 6 to 12 weeks.
No, see here, this patient is going to be on enoxaparin for the whole of pregnancy, right?
Yes.
So after 14 weeks, can you convert her into warfarin till 36 weeks? I would have done that. Thrombotic or mechanical valve, etc.
Then we can convert. Nowadays it is recommended up to 5 weeks. RPL mein nahi.
I think more for economic considerations it could be, but now we are not doing it anymore, no?
RPL we should not do, because the problem of, the mechanism of action of warfarin is vitamin K antagonism. Here we are worried about anti-prothrombin 3 or antithrombin 3 effect. That is why warfarin cannot replace heparin when it comes to RPL protection alone. Okay, when you are doing it for mechanical valve, things are different. Then we are more worried about teratogenicity, etc. So in those situations, warfarin is accepted, but for RPL, it is heparin only. Okay. Let us say, continuing with this, that this patient is APLA positive. So tell me, how would you take her with the enoxaparin?
I'll be starting enoxaparin based upon her history. I will be starting her on intermediate dose enoxaparin. That is, first I'll be starting her on 0.4 after confirmation of intrauterine pregnancy. I'll be starting on 0.4 ml SCOD, and as she gains weight in pregnancy, that is in second trimester, followed by third trimester, then I'll be changing the dose to 1 mg per kg.
Farajja, there is nothing called
network. Everyone is working, ma'am.
I think the network is going in the middle, no? Yeah. Till when will you continue the heparin aspirin?
Ma'am, heparin I'll be continuing till 36 weeks and aspirin 2 till 36 weeks. And if there is high risk, then guidelines have said that we can continue in labor also aspirin. But heparin to be stopped at 36 weeks because of unpredictable labor, spontaneous labor onsets. Better we start her on unfractionated heparin because anesthesia may be required, neuraxial anesthesia, epidural analgesia. And before the 24 hours of the onset of the labor or planned delivery, I'll be stopping her anticoagulants. And then, ma'am, I'll be restarting again this heparin after 4 to 6 hours of vaginal delivery, or at least 6 to 12 hours of cesarean
section till 6 weeks after delivery. We would continue.
Is there any role of anti-nuclear antibodies?
Yes, ma'am, if we are suspecting any other autoimmune causes like SLE, systemic lupus erythematosus, then we can go for, as a screening test, we can go for ANA testing.
But routinely
it is not recommended.
Is there any role of giving steroids?
Yes, ma'am. Studies have shown that if the like ecosprin and enoxaparin combinations are not like if we are starting on ecosprin and alone, if it is not that effective, then if along with that steroids plus aspirin, if we are giving 75% good pregnancy outcome is there. Like studies have shown, and if
I
enoxaparin,
don't think so. I don't agree with you. Now we are not giving steroids.
We are
They
no
have been
longer
shown to have more complications.
yes,
Like
PPRM and then also GD, diabetes infections and
osteopenia.
yes, ma'am.
What is the role of plasmapheresis or immune modulation just because you want to have a pregnancy outcome where you couldn't find any cause? What is the guidelines recommendation?
Ma'am, plasmapheresis can be done in cases of, it has not routinely recommended, but it can be done in cases of
SLE, autoimmune.
No, SLE and all you found. So you that becomes therapeutic, no? I'm saying you didn't find any cause simply because you want to give her a live pregnancy. Is there any role of interferons or immune modulators? No.
No.
Most of the guidelines, few of them say you could depending on the situation.
मैम नेटवर्क नहीं ये हमारा मैम का नहीं हाँ बाकी लोग
I think we've lost.
Ma'am, sorry, ma'am, could not hear you, ma'am. Network was lost.
Yeah. Dr. Gauri, you want to answer that and tell that?
Ma'am, I could not hear your question, ma'am.
No, I think the role of these sophisticated investigations like plasmapheresis and all are still, still under research, and they have to be, under very strict clinical trials and with a multidisciplinary and a multi-specialist team. Yeah. What is the role of things like intralipid and GCSF?
Ma'am, these are like new novel therapies under research that GCSF has been like it has been under research, ma'am, tried, not yet recommended, or HCQ. These are like novel therapies being recommended if the pregnancy outcome is not being improved by this recommended enoxaparin or aspirin combination. Then we can try for the steroids like prednisolone, HCQ, GCSF, immunoglobulin.
So they have basically been used to improve implantation rates. Now we come to the most frequently used treatment for RPL, and that is progesterone. Would you give progesterone? How much and how?
Ma'am, if in this scenario you are asking, ma'am.
Yeah, in the patient
when the patient is conceived.
When she's pregnant.
Ma'am, after confirmation of intrauterine pregnancy and then after cardiac activity, when cardiac activity has come, I'll be starting her on micronized progesterone, 400 mg, 2 taps.
You'll wait for cardiac activity?
8 weeks.
Why are you waiting for cardiac activity? What is the justification?
Ma'am, I'm waiting for cardiac activity because if I'm suspecting her on to be her APLA positive, already she's in a prothrombotic state, and then we are giving OCP like progesterone. It is
1 minute. Are we giving an OC pill or are we giving progesterone
therapy, ma'am?
Progesterone thrombogenic, they are not. Yeah. Progesterone is not thrombogenic.
Pregnancy
and progesterone, in fact, how does it act? Yes, Dr. Raj.
No, she is taking progesterone itself. In pregnancy, there is a high progesterone.
Correct.
So using progesterone as such, there is no, as Madam said, there is no need of waiting for the cardiac activity. You can start.
Yes, in fact, progesterone, we have to start very early because progesterone affects the balance between the mother and the fetus. No, there is a rejection, Do you know the theory of alloimmune etiology of RPL? Can you tell me something?
Yes, ma'am. Alloimmune etiology of RPL, it is based on like if the fetus has paternal genes and antigens as well. So two kinds of natural killer cells are there in the body, NKB1 and NKB2. NKB, it secretes TH1, which is anti-inflammatory, and then it secretes CD13, CD56, CD16. These are anti-inflammatory, and these helps in like implantation, ma'am. TH1, and then TH2 is pro-inflammatory. So
My mother will, there will be some blocking agents that will be secreted in the maternal.
So what happens in a normal pregnancy?
Ma'am, in normal pregnancy, if the baby has, if the mother has not derived her, if she is having her
No,
paternal.
just tell me in simple words, is the pregnancy accepted or rejected? That's all we need.
Accepted, ma'am.
It is accepted, whereas in a miscarriage, it is rejected. What is PIBF?
PIBF. No, ma'am. Sorry.
Progesterone induced blocking factor. No, progesterone secretes substances which favor acceptance and not rejection. Therefore, progesterone has to be started early. So now coming to which progesterone would you like? What are the options and how?
Ma'am, we can give micronized progesterone 200 mg 3 times a day vaginally, or
injection.
We can
Injection Proliton 500 mg weekly IM.
So would you give all of them? That
No,
the patient
ma'am.
is receiving weekly injections also, and she's receiving vaginal also and oral
No, no.
also?
Ma'am,
Just
one of
That
them.
should be allowed.
One of them.
Okay. A lot of patients would be on Dufeston also, Susten also, and injectable also. Is there any role of HCG injection instead of progesterones? Till
Ma'am,
12 weeks?
in luteal phase defects,
No, actually, its role has not been proven to be of use in clinical practice. Okay. What is PROMISE trial? Very interesting to read. PROMISE and PRISM trial. Read about it. It's very interesting because it talks about whether progesterone can be used in patients with recurrent pregnancy loss.
Okay.
And actually, if you see the results, they are not favoring it in its this thing. But I believe that it is prudence that in recurrent pregnancy loss, people do use it. Use the progesterone. Okay.
So let's come back to, I think, her patient. Your patient has now, after all those miscarriages, now conceived finally. Patient has reached, say, 8 weeks. Cardiac activity is there. Now what will you do further?
Since after cardiac activity, after confirmation of intrauterine pregnancy only, I'll be first investigating for her baseline, like platelet, hemoglobin, because I'm starting enoxaparin, ma'am. So I need to know her renal function test, and then I need to know her AST, ALT level, and routine antenatal investigations, which I advise along with that, ma'am. And then I'll be starting this enoxaparin 0.4 ml SCOD.
Suppose, yes, you will be starting. How will you monitor low molecular weight heparin? Is it
Ma'am,
necessary to monitor it?
No, ma'am. Low molecular weight heparin is not necessary to be monitored.
But suppose you want to monitor, how do you monitor it?
Factor 10A level.
Yes, you have to do factor 10A levels, which is much more sophisticated. Now this patient is APLA positive 8 weeks on your enoxaparin and your aspirin. How will you, what are the problems that you anticipate in this pregnancy? What are the problems that can happen?
Ma'am, in this pregnancy, apart from after starting these also, there may be intrauterine fetal demise or early pregnancy loss again. So I'll be like more, I'll be explaining her about signs and symptoms of like pregnancy loss, and then more vigilant follow-up has to be done. And then early anomaly scan, followed by detailed anomaly scan. And after 20 weeks, I'll be calling her for routine antenatal care visits every 4 weekly. And after 28 weeks, every 2 weekly, ma'am. And then with every visit, I'll be assessing her baseline platelet level, because she's on enoxaparin. So there might be chances of development of HIT. I'll be explaining her about signs and symptoms of bleeding or coagulation, and then explaining.
I don't think platelet is necessary when you're giving enoxaparin. It is necessary only when you're giving heparin. Okay. Typically with enoxaparin, there is no need to, because that does not cause thrombocytopenia. You said early malformation. You did not throw more light on it. You said early malformation scan. What do you mean by that?
हाँ, NT-NB मतलब early anomaly scan or early malformation scan is to rule out like trisomy 21 mostly. That
So
is,
you should put it as first trimester screen NT scan and not put it as early malformation scan. Okay. Would you be at this point, even though the patient is on enoxaparin, assessing her for preeclampsia risk?
Yes, ma'am. I'll be definitely assessing her for preeclampsia risk.
How will you do that?
Ma'am, I'll be doing her two tests can be done. Biochemical markers can be done, and this ultrasonographical. Biochemical, we can do PLGF, and in her early like first trimester, I can go for with PLGF and PAPE level, and then for ultrasound, by ultrasound, I can check for her this uterine artery PI.
Yeah, even though we are starting her already on aspirin and enoxaparin, but it will help us keep the vigil on to detect that, you know, whether she could be a candidate who has a higher risk for developing preeclampsia.
Yes.
Okay. So taking forward, you have done the malformation scan. How do you, everything is going fine? When do you want to terminate a pregnancy?
Ma'am, if everything is going fine, then we should continue her pregnancy up to 39 weeks, 39 weeks plus 0 days completed. And then we should like we can go up to term. 39 weeks plus 0. This has been given in guidelines, ma'am. We can carry her pregnancy till 39 weeks if everything is going fine. 39 weeks plus 0 days, and then we can plan her induction.
How will you screen for diabetes in pregnancy?
Ma'am, first in
oral glucose tolerance test. On her first visit, we will do 75 gram OGTT test, which along with HbA1c. If we are suspecting that routinely HbA1c is not done, we will only do.
What is meant by DIPSI guideline? What does DIPSI stand for?
Diabetes in Pregnancy Study Group of India.
Diabetes
so how is the
Group of India. What do they recommend for screening?
For screening, they it is recommended that at the first contact of the patient, we won't be waiting for 20 weeks to screen. First contact, we should straight away get 75 gram OGTT test done, and based on our fasting 1 hour and 2 hour levels, we may classify her.
No further.
1 minute, you said what you will do?
Is different.
Huh.
That is the international.
How will you do the OGTT?
It is
How will you
GCT
do
basically.
according to DIPSI?
DIPSI
It
is
is
what
GCT
test?
basically.
It's a
How will be, ma'am, you want to ask how should I be proceeding with the OGTT?
I'm asking, according to DIPSI, what is the screening test recommended?
According to DIPSI, there is no requirement of fasting of 8 hours. There is not recommended, and then 75 gram oral glucose is given.
Yes.
And then
we'll collect sample after
1 hour and 2 hours. If the patient
a single sample after 2 hours.
No.
The single sample after 2 hours. Single sample. Irrespective
And
of
it is
fasting.
taken as
Why
a
is this?
diagnostic test.
It is one step test.
Yes, one step.
It's a one-step screening test. They have made it very simple. Patient doesn't have to be fasting. Give 75 gram glucose 2 hours later. Check the blood sugar. And what is the cutoff level?
140. If it is less than, if it is more than 140, then we'll diagnose as diabetes.
And if it is
As
more
GDM.
than
Yes, and between 120 to 140, impaired glucose tolerance. Yeah. Dr. Ashok Kumar, you
Yeah, madam, no, just I want to tell you only 5 minutes are left. If you have anything more to finish off, then we can ask them quickly.
I think the only thing that we have not covered, because the history did not derive us or drive us into it, is incompetent cervix. So, you know, what would be the classical history? How do you go about diagnosing in the intercurrent period? How do you diagnose it during pregnancy? And how do you manage it? Which I think I will leave it to the students to discover
Yes.
from books, because that entirely depends on the particular case.
Can we, Dr. Ashish Mukhopadhyay is online. Can we confirm that? Sir, are you there?
No, sir, he is not here.
Achha, he was there in between. So only thing which we want to do in the end, if Dr. Sarita and Dr. Gauri, if there is nothing more, Dr. Rajesh, anything you want to ask further, then we would just want to do one more exercise with them.
Dr. Farhat, you said that you will wait till 39 weeks. Okay, but after 36 weeks, suppose you have to, suppose she has got oligohydramnios. How will you manage?
Sir, after 36 weeks, I'll be, if she has got oligohydramnios, I'll be screening for her, like blood, what are the pleasant, is there any kind of placental insufficiency? And then I'll be starting her on injectable hydration therapy along with oral.
What investigation would you like to do at this stage? So, oligohydramnios, but detail what you want to do, sonography or color Doppler, anything like that?
I'll be doing, yes, sir.
Yes.
What in the Dopplers will help, will guide? Later
So,
on,
after 36 weeks, so I'll be checking for both umbilical artery, uterine artery, and MCA, everything, and based on that, I'll be calculating CPR.
Uterine artery is not required.
Uterine artery.
Uterine artery not required. CPA.
CPR.
CPR,
because this is an area where the baby may be well grown, but still undergoes insufficiency and causes problems. So CPR becomes important there. Okay. So oligohydramnios is a very subtle clue that there is something likely to be affecting the babies. So we have to be very vigilant at 36 if sir said that there is oligohydramnios developing. We cannot take it lax till 39 weeks. We may have to intervene.
37 pe I'll induce, sir, and if any obstetric indication will be there, at term I'll be terminating.
Yes, you have to terminate it.
Okay. So in the end, just we would like everyone to know that, see, in the exam, when you are ready with your case and you write everything on your examination paper about the case, history, examination and everything. But when you appear in the exam and you are in front of the examiner takes away your that paper, right? Because he wants to see or she wants to see what all you have written and how you have written. And simultaneously, examiner will ask you to present the case. So you are now without paper, right? So in that scenario, you have to present your paper, present your case, and that is what we label them, that whatever you will recall, you will not be able to recall finer detail. You will not be able to recall the data of the patient, but whatever you can present at that time is the summary of the case, right? So that is in the nutshell the summary. So you all should practice about how you will prepare your summary and how to present your summary, right? There's so many things which are there, as we have seen in the first case and in the second case. So we have to be really prepared ourselves for our summary. And sometime even the examiner asks you that to present only the summary, not the full case. So summary should have all the positive and negative relevant details, and it should not be very short, and it should not be very long also, and it should not be read by the paper. You should not see the paper when you present the summary, right? So that exercise everyone should do whenever you are preparing a case. So that is what we wanted to add here, that this exercise is a must, and always we ask our student to prepare a summary of the case. So that if there anything, and in the chat box also we are not queries from the student, if there's anything we can answer, or if any query or any suggestion from the audience or the participants, we are most welcome at this stage. In 1 or 2 minutes we can wind up then.
So I think let's first start with congratulate Dr. Farhat and Dr. I forgot the other doctor's name is?
Akriti.
Dr. Akriti, yes, I think they've done a very good job. Congratulations. What do you think, Dr. Gauri and Dr. Rajesh?
Absolutely. Very good.
Nicely done. Nicely prepared. They're well read.
I will go one step further, that you all as a faculty, as an examiner, have also done a very good job to extract and to prepare the scene of this PG tutorial today. So that and we have this the evidence is there in the chat box. Someone has commented about the very good session by the expert also.
Thank you,
Thank
Dr.
you very much, sir.
Thank
you, Dr. Sarita, Dr. Manjeet, Dr. Rajesh.
Thank you.
And thank you, Dr. Ashok, for the opportunity. Thank you
Dr.
very much.
Hafiz,
Yes, sir.
over to you.
Yes, sir. I think as again the students has done very good. So they have been preparing hard for over. I think we have communicated for at least 3 or maybe 4 weeks back, and they have done good. And that's what I would like to say. And I'm sure this will give them lots of confidence for future in presentation. And at the same time, I'd like to tell the students that is we have our all recording of the last 1 year program. So just they can go to the ICOG website and can have, they can observe all those, and that definitely is going to improve them in those presentation of the cases. So thank you all the students and
Dr. Hafiz, 1 minute. Dr.
Yes,
Sarita wants to say something. Dr.
Yeah,
Sarita
I
from
must
Raipur has.
congratulate Dr. Ashok, Dr. Lakshmi Shikhande for this program, and Dr. Hafiz was well coordinated. I just want to give a message to the PG student who are attending over here as what my student missed in this presentation.
Yes,
It's something like they had the diagnosis of APLA and they were just focusing on the APLA. So it is very important, and you should not be very much focused on one condition if you reach to the diagnosis. As in this case, you were in the anatomical causes were discussed very well. And then you were discussed about the genetic causes also. And then you were discussed about the hysteroscopy, laparoscopy, when and what. And then the another thing which our PGs missed is that how to do the follow-up of this pregnancy. In that case, it was very important, the early anomaly scan, lattice anomaly scan. Before that, the growth scans are important to rule out the FGRs. And the follow-up in each visit to rule out the pre-eclampsia is very important with the blood pressure monitoring and the urine albumin test. And sometimes we do the ACR also. And because this patient has an intrauterine death at the 30 weeks of the gestation, the more rigorous monitoring is required in this case with the Doppler. So if you find any Doppler anomalies, then the management will go like in a Barcelona protocol. So my student would have told about the Barcelona protocol. If there's an FGR, if there's an oligohydramnios, what will be her next step? It is not like that you can blindly go up to the 39 weeks. The follow-up protocol is going to take you to the decision what next. And the job is not over after the delivery. You need to follow up this patient up to at least up to the 6 weeks.
Yes.
Because even as a single APLA positive and everything pregnancy event is normal, there can be the postpartum catastrophes in this patient. So this is the message I wanted to give. It's not like you should focus on the condition which you had diagnosed, but other things also should be looked for. So anyway, congratulations, Bharat and Akriti, you did the good job. And the examiner also being so humble.
Yes.
Thank you, Madam Sarita, for your comments.
Madam. Yeah. And
So,
thank you, madam, for
Thank
your
you.
help in arranging this case presentation by your student. Thank you very much.
Yeah. So I, sir, I would like to thank you, that is the students, both SK, MCH, and as well as the ICS Raipur, and all the faculties for their valuable, that is time, as well as their inputs, important inputs. And I'm sure that this is going to help all the students, those who are observing, as well as this information will be recorded in the ICOG website as well as in the YouTube, and this is going to be definitely helpful for all the students. Thank you so much. Ashok sir, anything more? So next month,
I just want to thanks once again all my faculty and the students who are there
Yes,
today for your participation and interactive discussion. I think this will go a long way in helping the students and updating the knowledge. And this is what the ICOG FOGSI under the presidency of Dr. Rishikesh Pai and chairmanship of Dr. Lakshmi Shikhande wish to do, that we have good academic institutes and good academic discussion by the FOGSI ICOG, and students should be benefited because they are the future of our country. They are the future obstetrician and gynecologists. So their concept and their knowledge should be updated regularly, and so that in future they will take care of all the patients carefully. Thank you very much.
Thank you.
Next month 15 we'll have some January